Bismillahirrahmanirrahim. Honorable Chief Guest, His Excellencies, distinguished guests, ladies and gentlemen, Assalamu alaikum, and a very good morning to you all. I'm Hazima Mozum, and on behalf of OIC Comstech, it is my honor to welcome you to the 8th NRAM Comstech Regional Seminar of 2025 on plant materials and their clinical validation in the management of diabetes and metabolic disorders, their challenges and scope. We are delighted to host our eminent scientists, clinicians, researchers, policy leaders from Pakistan, Bangladesh, OIC member countries, and around the world. To formally begin today's inaugural ceremony, I request all the distinguished guests to please rise for the national anthem of Pakistan and national anthem of Bangladesh. Ladies and gentlemen, I request our guest of honor, His Excellency Mr. Iqbal Hussain Khan, High Commissioner of Bangladesh, to please come on the front desk. Please welcome him. To seek the blessings of Allah Almighty, we will now play the recitation from Holy Quran. Jazakallah. Ladies and gentlemen, to officially welcome our guest and to open the seminar, I invite His Excellency Professor Dr. Muhammad Iqbal Chaudhry, Coordinator General, OIC Comstech, to deliver his welcome address. Please welcome him.
Excellency, my dear brother, Mr. Syed Mustafa Kamal, the Federal Minister of Health, Excellency Ambassador Aftab Khokhar, who will be joining us, the Assistant Secretary General, who I see online, Excellency, dear brother Iqbal Hussain, the High Commissioner of Republic of Bangladesh, very renowned scientist, a great friend of Pakistan, and health professional par excellence, Professor Dr. A.K. Azad Khan from Bangladesh University of Health Sciences, my dear sister, Professor Dr. Ruqayya Begum, Secretary of Asian Network for Research on Anti-Diabetic Plant, distinguished participants from various countries, ladies and gentlemen, Assalamu alaikum and good morning. It is my distinct honor to welcome Excellency the Minister, members of the delegation of scientists from Bangladesh, Australia, UK, Sri Lanka, and other OIC countries, and all of you to the inauguration of the Comstech and RAP joint seminar. I've had the honor of knowing honorable ministers since last 3 decades, and I'm truly inspired from his patriotism, capacity to perform well against all odds, his leadership, and most importantly, his sincerity of purpose. He is a shining example of the best of human attributes and professionalism. From mayor of one of the largest cities of the world, Karachi, To various ministries, he has always outperformed. His peers have made us proud. Thank you very much for being part of this. Ladies and gentlemen, my remarks are just divided into present and future, and I like to present very briefly what present look like. World is confronted with enduring challenges of immense health burden, intertwined with poor living conditions, impact of climate change, weak healthcare system, and immense poverty. Sustainable Development Goals, health for all, appears to be a pipe dream, unlikely to be achieved by any nation in Global South by 2030. Along with this, we still have a huge scientific gap in our understanding of diseases at the molecular level. As a result, we are only able to manage diseases and not effectively treat them. 21 globally recognized fungal, parasitic, and other zoonotic diseases, collectively called neglected tropical diseases, are affecting the lives of billions of people all across. Yet there is a very little attention and funding for the prevention and treatment of these foreman diseases. Malnutrition, stunting, and other menace which affects our people profoundly and so immensely. Pharmaceutical industries are businesses who are by design and not by default invest in the management of diseases rather than finding their cure. As a result, majority of the human disorders are only managed and they're not treated, be it is a diabetes, dementia, cardiovascular diseases, arthritis, Alzheimer, or Parkinson, you name a few. And this is the present situation, which actually tells us that we are in the midst of immense health crisis. Future, ladies and gentlemen, the future of healthcare will be centered around a holistic approach, around understanding and identifying social and demographic determinants of disease prevalent in certain regions and certain population group. This knowledge will form the basis for an integrated healthcare system, which is based on evidence-based policies geared towards the prevention of disease through relevant research and appropriate intervention. We need to understand that pharmaceutical interventions are just a very small contributor to human health and wellness. Clean water, proper sanitation, decent living conditions, balanced diet, healthy environment, and meaningful social lives are foundational pillar of healthy communities. COVID-19 was not the last pandemic humanity has faced. There are so many of such catastrophic pandemics we will experience during our lifespan. Therefore, pandemic preparedness has to be at the center of future of healthcare systems. For developing countries like ours to achieve health security, it is imperative that we build our own capacity to trace and track emerging diseases and to invest in indigenous manufacturing of biomedicine, biologicals. This is what Honorable Minister is trying to do. His focus is holistic. On one side, he is conducting a lot of policy interventions to make this system more geared to patient-centered care and future-ready. On the other side, he's developing indigenous capacity, including vaccine, within the country, so we are prepared for the next pandemic. An effective and seamless integration of evidence-based traditional medicine is extremely important. We just discussed that traditional Unani medicine, which we all practice in many of our countries, including Arab medicines and Islamic medicine and Central Asian medicines. We have the honor of welcoming honorable ambassadors with us also. They're extremely important. They need to be linked with research. We need to invest a seamless integration through policy and through intervention. Ladies and gentlemen, coming to the topic of this very important event, diabetes is among the most enduring health challenges of the modern world. Despite tremendous development humanity has faced to control this major health issue, environmental and lifestyle factors have magnified the impact of diabetes and associated disorder. It is time for us to go back to the nature, from lifestyle to diet, from social life to habits, and as well as in medicine. Today's event is an effort to highlight how nature, especially medicinal plants supported with strong research base, can contribute to prevent and treat diabetes. OIC comstech has launched many major programs in its 57 member states in 4 continents with 2 billion of population. And those programs are centered around developing capacity in healthcare through human capacity building, institutional strengthening, as well as developing inter-Islamic cooperation to handle major health problems. Currently, we have programs in 11 countries of the world. And that is an extremely important facet that highlight Pakistan's health diplomacy to a very large portion of the world. I'd like to end my remarks by sincerely thanking our chief guest, very dear to my heart, Honorable Minister Sayyid Mustafa Kamal, our distinguished participants from various countries, ladies and gentlemen, for your presence here, and most profoundly, my own team from Comstech as well as from ANRAB, that they have made this work so possible. And the job has been very well done. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much, sir, for your inspiring words. To provide an overview of the seminar and its scientific foundation, may I now invite Professor Dr. Begum Ruqayya, Network Leader and Secretary General of ANREB, Dean at Bangladesh University of Health Sciences for introductory remarks. Please welcome her.
Honorable Chief Guest of this inaugural program of the 8th ANRAB Comstech Regional Seminar, His Excellency Mr. Syed Mustafa Kamal, Federal Minister of Health, Ministry of National Health Services, Regulations and Coordination, Government of Pakistan. We have guest of honor, His Excellency Mr. Iqbal Hussain Khan, High Commissioner of the People's Republic of Bangladesh, Embassy of Bangladesh, Islamabad, Pakistan. Guest of honor who is joining online, His Excellency Mr. Aftab Ahmed Khokar, Assistant Secretary General, Science and Technology, OIC. Professor, our National Professor, Bangladesh, A.K. Azad Khan. He's the President of Diabetic Association of Bangladesh. And our beloved brother, Professor, His Excellency Professor Dr. Muhammad Iqbal Chaudhary, Coordinator General OIC Comstech, and distinguished scientists sitting in the hall room, and participants from who are joining online and who are sitting here. Ladies and gentlemen, Assalamu alaikum and a very good morning. I feel honored and privileged to introduce the background of ANRAB and about this seminar. Ladies and gentlemen, we all know that diabetes mellitus is a complex, heterogeneous group of disorder which is increasing in an epidemic rate. The International Diabetic Federation predicts that by the year 2050, there will be a 45% of increase in the number of diabetic subjects globally. And the population of the developing countries will suffer the most, mainly due to urbanization, then changes in food habit, and also just less physical activity. We all also know that, and it is established that diabetes is not a single disease. When there is diabetes, there is, in diverse tissues, there are abnormal. So it is very difficult to get a single agent that would actually cure that serious disease. So nowadays, what we have in our hands, we have so many glucose-lowering agents like insulin secretagogue, insulin sensitizers, incretin mimetic. Then we have SGLT2, sodium glucose cotransporter inhibitors, DPP4 inhibitors, etc. But they have got severe adverse effects, and majority of the cases, they are not affordable by the common people. So we know that almost 80% of the developing countries people use plant materials as their primary health care. So it is very much imperative to scientifically evaluate the folkloric reputation of the plant materials they are taking for their treatment. So again, we know that multidisciplinary pharmacological target, we have so many plant materials that we can test. So with this background that plant materials should be tested as indigenous medicine, with this background and thinking that chemical and biological work should be done together. So collaborative work has been started in the year 1990 and 1901 between BARDEN, that is Bangladesh Institute of Research and Rehabilitation in Diabetes, Endocrine and Metabolic Disorder, and Chemistry Department of Dhaka University, Bangladesh, and Uppsala University, Sweden, and also in Mahidol University, Thailand. So it was felt appropriate that to make the workshop to change the views and expertise in this field. So with the financial support from EPICS, International Program in the Chemical Sciences, and IFS, International Foundation for Sciences, a workshop was done in the year January 1992. With the great enthusiasm seen in that workshop, an international seminar was done in the year 1994 January, and in that seminar, the seminar recognized that a multidisciplinary concerted effort or move should be taken to treat such an incurable disease like diabetes from plant sources. So a proposal for formation of UNRWA was taken that time in the year 1994. Then the Dhaka group prepared a proposal to form UNRWA, an Asian Network of Research on Anti-Diabetic Plants, and it was placed in ACDC meeting in Malacca, Malaysia in the year 1995. And this in the year 1995 January, and this was adopted unanimously because it was the proposal was made by Professor Mosi Zaman and Professor Nilufar Nahar. And in that Malacca meeting, there was a representative from UNESCO, FASA, IFS, ISP, etc., and they all accepted this proposal, and therefore UNRWA was launched in January 1995 by that meeting. And the ad hoc committee of that workshop, organizing committee of that workshop was taken as ad hoc committee, and they took the constitution of UNRWA. So UNRWA has been formed with a board. A board member was there that time, Professor Mosi Zaman. The first UNRWA board was Professor A.K. Azad Khan, who is sitting in the dais, and Professor Eric Karunanayake from Sri Lanka, and also Professor Abhijit Banerjee from Kolkata University. And in course of time, the UNRWA board has been changed, Professor Mosizaman is in the chair. I have, Professor Azad Khan was until 2015 the Secretary General. Then I became Secretary General in 2015, and under board now constitutes with other three board members, Professor Iqbal Chaudhary from Pakistan, Professor Khudira Shari from Malaysia, and Professor Banusri Hazra from Kolkata. And UNDRAP, this is now UNDRAP is what UNDRAP is doing. UNDRAP is trying to optimize, to coordinate the facilities of different laboratories to work on anti-diabetic plants, chemically as well as biologically. So UNDRAP organizes workshop, hands-on training workshop, seminars, it may be national, it may be regional, and it may be international. So we had so many conferences in Pakistan. We had in 2019, we had organized third international seminar in Karachi, Pakistan. So but you know, EPICS, ISP is the sponsor of UNDRAP, this network, but the SIDA actually sponsored them, but there is a cartel in budget. So Professor Iqbal Chaudhary, when he was in Dhaka, we had a meeting with our chairman, and he's then proposed that we can arrange UNDRAP jointly, UNDRAP comstech regional seminar. That's why he was so much instrumental in making this seminar. So thank you, Professor Iqbal Chaudhary, from the heart. And we are now here to organize this 8th regional seminar here. So in this seminar, you can see there are lots of lectures. This is a hybrid seminar. People will be delivering lectures from different countries, and in person and online. So I forgot to mention one thing, that at the very beginning, UNDRAP was concentrate only on anti-diabetic plant materials on single plant, but later on, UNDRAP expanded its domain of activity to herbal medicines, and also to herbal medicines with non-communicable diseases, because we know that plants contain thousands of compounds. So some of them may be active for the treatment of many more diseases. So you can see so many lectures, and I really think that all the lectures are very much valuable. And in this seminar, we will gain, of course, we will expand our knowledge going, and after finishing the seminar, we enrich our knowledge. I do believe in that. So, ladies and gentlemen, I thank you all for being here, and I hope you will be beneficial. You will be benefited in the lectures, which will be delivered here today and the day after and tomorrow. Thank you very much for your patience hearing.
Thank you very much, Madam, for providing the valuable context and background. We are honored by the presence of His Excellency Mr. Iqbal Hussain Khan, High Commissioner of People's Republic of Bangladesh in Pakistan. May I request him to kindly deliver his remarks. Please welcome His Excellency.
Assalamu alaikum. I am very happy to be present here in today's important seminar that is organized by UNDRAP and comstech regional seminar jointly they have organized. I am also very happy that delegations from Bangladesh is here. I would like to thank today's chairman of the meetings, Dr. Muhammad Iqbal Chaudhary. My name is also Iqbal. And here's present Honorable Federal Minister for Health, His Excellency Mr. Syed Mustafa Kamal, and also Assistant General Secretary of the YC, who is present, I think, online. And here's the Dean of the Diplomatic Corps and also distinguished ladies and gentlemen. I just would like to mention few words that this is the very highly technical seminar. I do not have nothing to say on these matters. Just I mention few words about the context of Bangladesh, Pakistan, and OIC relations. Bangladesh, there's was a part of United Pakistan for more than 2 decades. And then we became independent in 1971. In last 15 years, the relations between the two countries was in a very minimum levels. But from August 2024, after revolutions, the relations between Pakistan and Bangladesh is getting better day by day. And now high-level delegations visiting each others from military as well as from the civils. And also in the field of education, many delegations visiting each others. And in the coming days, we hope that these relations will be strengthened in all spheres of economic, trade, and tourism, and even in the health sector cooperations. In Bangladesh, I can say proudly, there's most talented students, they opt for to study medicine. And they are brilliant doctors, but unfortunately, uh, the whole health system did not improve as per the expectations of the common people. We need to improve that sectors. So the government of Bangladesh is giving high importance on improving the health sectors. My presence about 11 months in Pakistan, I found the health sector of Pakistan, alhamdulillah, very good. Even nowadays, the patients from Bangladesh are giving options to visit Pakistan. There was one barrier, it was absence of direct flight. The Bangladesh and Pakistan, both sides is working hard to have direct flights. And inshallah, we are expecting at the end of this month, the direct flight will be established. That will facilitate uh, the people-to-people contact in the field of health, tourism, education, trade, and commerce. In the last 10 months, I have visited some hospitals of Pakistan. I found that the doctors and nurses here are highly qualified. I appreciate their competence. Even sometimes I see in the media that they are globally highly appreciated. So I believe that this 2 day long conference will benefit all concerned. And OIC, actually, sometimes the young people, they do not have enough trust on the OIC. They think that it is not a active organization. But our forefathers, they established with the hope that the cooperation among the Muslim countries will benefit the Muslim nations in the security, in the political area, as well as in the science and technology. But development of science and technology in the Muslim world is much lagging behind. Today, I had another invitation from the Space Research Institute of Pakistan. I also feel that in the space area, the Muslim world is lagging behind, far lagging behind, with compared to the other part of the world. So time has come to encourage our young people to give their attention in the study of science and technology. Without improvement of the science of technology, no nation can achieve their standards of life and also their economy. So I thanks the organizer for giving the opportunity to be here. From my office, my team will join in this seminar, and I hope that our cooperations with our Pakistani brothers and sisters, and also with the others Muslim countries, scientists who are working in the science and technology, we will be able to have a respected positions of the health sectors in the respective countries. with these few words and wishing the success of this seminar, I'm ending here. Thank you so much. Assalamu alaikum.
Thank you, Excellency, for your thoughtful and encouraging message. Ladies and gentlemen, now we will hear message from His Excellency Mr. Aftab Ahmed Khokar, Assistant Secretary General, Science and Technology at OIC, Kingdom of Saudi Arabia.
Rahim. Coordinator General Professor Iqbal Chowdhury, the Honorable Minister of Health of Islamic Republic of Pakistan, distinguished scholars and researchers and participants. It is a great prayer and honor for me to represent the Organization of Islamic Cooperation at this important scientific gathering, which has jointly been organized by comstech and the Asian Network of Research on Anti-Diabetic Plants, NRAP. I bring to you warm greetings and best wishes from His Excellency the Secretary General of the OIC. I take this opportunity to commend comstech for its continued leadership in taking initiatives relating to promoting science, technology, and innovation across the Muslim world. The focus of this particular seminar, which is plant-based materials and their clinical validation in diabetes and metabolic disorders, addresses one of the most urgent and pervasive public health challenges confronting the OIC member states today. Diabetes and other metabolic disorders are rising at an alarming rate, particularly in the OIC countries, where health systems continue to face a dual burden of infectious and non-communicable diseases. According to the World Health Organization, more than 400 million people currently live with diabetes globally, a figure projected to rise to 578 million by 2030 and 700 million by 2045. These statistics are not yet mere numbers. They represent millions of families facing economic hardship, suffering, and diminished quality of life. Against this backdrop, the exploration of safe, effective, and affordable therapeutics derived from natural products become not only a scientific necessity, but also a moral imperative deeply rooted in the cultural and medicinal heritage of our societies. It is encouraging to note that this seminar brings together over 25 eminent experts from Bangladesh, Pakistan, Australia, Sri Lanka, China, and several other countries, along with the participation of more than 150 scholars and practitioners in person and online. Such wide engagement reflects the growing recognition of the potential of natural and traditional medicines as an important complement to modern therapeutic approaches. This initiative is fully aligned with the OIC Science, Technology and Innovation Agenda 2026, particularly in its objectives to promote health research and biotechnology for disease prevention and treatment, to enhance capacity building and collaborative R&D among OIC member states, and to advance the scientific validation and value addition of traditional and indigenous knowledge systems. Under the able leadership of Professor Dr. Iqbal Chowdhury, comstech has played an instrumental role in fostering research networks, developing human capital, and advancing South-South scientific cooperation. NRAP's long-standing contribution to natural product research, especially in the area of anti-diabetic plants, are equally commendable. Their collaboration exemplifies how regional partnerships can generate tangible scientific and social benefits. Together, comstech and NRAP have created a vibrant platform for translational research, evidence-based validation, and the cross-pollination of knowledge across Asia and the wider OIC region. However, to harness the full potential of traditional medicine, we must address several critical challenges. Among them are: number one, the need for stronger clinical research capacity within the member states. Number two, the establishment of quality control laboratories for herbal and natural products. Number three, the development of harmonized regulatory guidelines for herbal and traditional medicines across the OIC countries. I encourage the distinguished participating scientists and institutions to use this seminar as a springboard for deeper cooperation through joint research, data sharing, training, and exchange programs under the comstech-oic frameworks. Let us also work collectively towards establishing centers of excellence in natural product research across our regions, linking universities, research institutions, regulatory authorities, and the pharmaceutical industry. In this regard, it is important to build partnerships with outside OIC family members. We have seen a lot of research and knowledge in other countries. We must take advantage of that. In conclusion, I wish to once again commend Comstack, NRAP, and all participating institutions for organizing this timely and important seminar. I am confident that the deliberations and outcomes will generate actionable recommendations that will strengthen regional research collaboration and advance the discovery of novel, affordable, and culturally relevant solutions to diabetes and metabolic disorders. The OIC Secretariat stands ready to continue supporting such collaborative endeavors that enhance the collective scientific capacity, health security, and well-being of member states and the people in our member states. I thank you.
Grateful to His Excellency for his message. It is indeed my honor to invite our chief guest, His Excellency Mr. Syed Mustafa Kamal, Federal Minister of Health, Ministry of National Health Services Regulation and Coordination, Government of Pakistan. Please welcome him.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي صلى الله عليه وآله وسلم. His Excellency Professor Dr. Iqbal Chaudhry Saab, my brother, Excellencies from different parts of the world, Excellencies, the ambassadors, Excellencies, professors, doctors from our brotherly country, Bangladesh and other parts of the world. Ladies and gentlemen, to everyone, Assalamu alaikum and very good morning to all of you. It's indeed a pleasure and honor to witness this gathering and listen to all of you and to know what's happening from today onwards till 2 days, 2 days in this hall. Well, when you talk about the topic which we have today of this conference and seminar, plant materials and their clinical validation in the management of diabetes and metabolic disorders, challenges and scope. Doctor says people who know the subject, they say this diabetes is the mother of all evil. And out of 4 people here in Pakistan, 1 is a diabetic patient here in Pakistan. Just imagine the population, 240 million people. Every 4th person is a diabetic here in Pakistan. And that leads to many diseases, which is compounding together and, coming back to our health, the burden coming back to our healthcare system in Pakistan. How would on this earth any government or any society would be able to take care of these many people, if sick people with a very humble and challenging infrastructure. So, like always, it's been always said by the people who knows the subject, that prevention is better than cure. And this health sector, to me, is enabling people not to fall sick. is creating an ecosystem, an environment where well-being is being observed, where the well-being of the people, of the person, of humanity being observed. It's not the entire, on the contrary, in our country, the environment and everything today, very unfortunately, this is a challenge. But yes, we do admit the challenge, and the environment is that the entire environment of Pakistan and of this region is enabling people to fall sick. And then we wait in our hospitals, we build hospitals, tertiary care, huge hospitals, with infrastructure, doctors, paramedics, and then we wait for the patient to come. And this is where the competition is going on. So to me, after having this responsibility for last couple of months, the entire health system has an emergency. It's a collapse system. Because no matter how many hospitals you will build here in Pakistan, you would not be able to fulfill the requirement of the health of the sick people's burden. No matter, that's why you go to any hospital here in Pakistan, you'll see it's flooded with the people. And just because the environment, just because all those necessities, all those precautions which should have been taken care before in this environment, that's not there. So like Professor Iqbal Chaudhry Sahab has just mentioned in his talk, that these pharmaceutical companies, it's a business. They manage the disease. They don't cure the disease. And just yesterday I was in Karachi in one of the Unani medicine pioneer here in Pakistan. I was with them. I was in their facility. Very unfortunately, here in Pakistan, we could not promote and acknowledge the traditional medicine the way it should have been. So this is very close to my heart. The topic you will be talking in these 2 days. I've just requested our brother Professor Iqbal Chaudhry Sahab that I need to have the entire procession's video link, and we need to promote traditional medicine. We need to promote clinical trials. We need to have some biological evidence on it, and we have to glamorize this. We don't mention any success stories, Doctor, that out of this whole traditional medicines, through the traditional medicine, how many people we have cured so far? How many diseases we have cured so far? How much prevention we have managed so far? There's no storytelling anywhere. And there are many in the society, but we have not been able to glamorize it, market it in a way, the way it should have been. So the results are not there. The trust is not there. The connectivity between the people and these medicines are not there. Just yesterday, we decided, inshallah, and I'm going to work on it, inshallah ta'ala, that in our hospitals, there has to be a traditional medicines desk as well in the same hospital, inshallah. We have to create a space. We have to create a position. Where would all these qualified people will go? How many people these companies will hire? How many students, qualified students, will have their own tib? So there's no the mechanism, the ecosystem is not there. The encouragement is not there. And like it's been said, always say, the prevention is better than cure. And I was just mentioning about the cure, that we have to make people, enable people not to fall sick. The environment, and that's not the responsibility of any health ministry, to prevent people not falling sick. That's the responsibility of each and every soul, the entire society. For instance, Like we say, 70% diseases are the waterborne diseases. We normally say that's the calculus. 68-70% diseases are the waterborne diseases. So that means that you have to provide the clean drinking water. That's not the job of the health minister. All the way from Gilgit-Baltistan till Karachi, we do not have the sewage treatment system in Pakistan. I'm sorry I say it, just to recognize the problem, so that we will have the solution for that. Unless and until you don't recognize you don't diagnose the problem, how would you come up with a solution? So right top on the mountain there in Gilgit-Baltistan, a neighborhood which flushes their sewage, there's no sewage treatment. It goes to someone's drinking water, the next neighborhood. Through all these river, stream, other sources. And when they flush their own sewage, it goes to the another neighborhood, clean drinking water. Yet we call the 70% diseases are the waterborne diseases. When there's no sewage and there's no chip in our national mindset, we don't see it as a problem. Very unfortunate. Any officer or office or authority which is approving that neighborhood allowed to be built, would they look at it? What's the checklist? Whether they will provide the roads infrastructure or not, whether they will provide the parks or not, will build mosque or not, will provide the electricity or not, will provide the gas supply and drinking water supply or not. Nobody has seen till today that whether they will be provided, that neighborhood will be provided the sewage treatment plant for that neighborhood or not. Not even a single neighborhood or housing scheme has been cancelled not to have the sewage treatment plant. So, ladies and gentlemen, blaming an authority is an easiest task. But is it helping someone? No, it's not helping anyone. We all have to be very cognizant, every soul. We have to hate everyone. It starts from that human being to take care of themselves. We have 13 vaccines available here in Pakistan to prevent the diseases, which the government of Pakistan provides free of cost. It's available to every child. But yet there are certain amount of people who refuses to take that vaccine. What would you do that to that people? They are till today the zero dose children here in Pakistan, 360,000. Those are potential human being to fall sick. They're in Pakistan. So we all have to be very cognizant about our own health. Then only this burden of diseases could be reduced. Yes, government has its own role to play. And government is not the ideal situation. There is an ideal situation here in anywhere, but we all have to work to first. We all have to understand it. It's not that everybody will fall sick and government will take care. No, that's not the case. We have to work on those lines where we should not fall sick. We should be preventing those diseases. So conferences like the government of Pakistan, we are fully supportive. We are with you. Definitely, the leads should come from there. We call ourselves as a facilitator, and anything and everything which is needed to be done by the government, by the health ministry, rest assured it all will be done. And this is what the aim and objective of this entire ministry is, that we have to convert this sick care system to an health care system. To sick care system to an healthcare system. That's why I'm not interested in building many hospitals and waiting for the people to come fall sick and then come and get their treatment there. So I would congratulate Dr. Professor Iqbal Chaudhry Saab and all the distinguished guests from different part of the world for your contribution. I wish you a pleasant stay here in Pakistan. I wish this conference will have some real fruit for the common people, not only in Pakistan, for the entire OIC region and entire world. And together, inshallah ta'ala, we will be able to mitigate these challenges and will come up with something which will be beneficial for the entire humanity. With these words, thank you so very much for giving me this honor and bringing me here. Bahut shukriya.
Thank you, Excellency, for your wise words and for gracing us with your presence. Honorable Chief Guest, Excellencies, distinguished guests, as we conclude the inaugural ceremony of this seminar, it is my honor and privilege on behalf of Comstech and the organizing committee of NREB to extend heartfelt vote of thanks to all those who contributed to the organization of this event. We are sincerely grateful to our chief guest, to our guest of honors, to the excellencies from various OIC member countries for gracing the seminar with their presence and for their encouraging remarks, which have added a great value to our collective effort. Our deepest gratitude to our distinguished speakers and experts who have traveled from across the world to share their valuable knowledge, research, and experiences. It is indeed an illustrious gathering of senior scientists and towering personalities such as Professor Dr. A.K. Azad Khan, Professor Dr. Vijaya Kumar, and Professor Dr. Berry, and many others. Your distinguished speakers, your insightful presentations will no doubt enrich our understanding of plant-based therapeutics and highlight the immense potential and challenges of the clinical validation. Thank you very much, ladies and gentlemen, to all our participants who have joined us here in person and virtually for your presence. May I now request His Excellency Professor Iqbal to present shield to our chief guest, His Excellency Mr. Mustafa Kamal, for his presence. I request our other inaugural speakers to please join. Okay, ladies and gentlemen, we will now go for a group photo followed by high tea. Please join us outside. Thank you very much again for your presence. We will begin our technical session here at 11:20 a.m. Ladies and gentlemen, we are starting our first technical session. So I would request our speakers for the first technical session, National Professor Dr. A.K. Azad Khan and Professor Dr. Ruqayya on the stage, please. Yes. Ladies and gentlemen, this session will be chaired by Professor Dr. Mudassir Israr, who is advisor OIC Comstech. So with permission from Madam, I would request Madam Professor Dr. Mudassir Israr to please invite and introduce our first speaker, Professor Dr. A.K. Azad Khan. Over to you, Madam. You can do it over there.
Assalamu alaikum. It is an honor for me to welcome you all to this very important conference of plant materials and their clinical validation in the management of diabetes and metabolic disorders. I extend my deepest appreciation to all speakers and participants for being here to address one of the most urgent global health challenges. Our first speaker today is Professor Dr. Abdul Kalam Azad. He is basically a professor of gastroenterology, also served as dean at the Hamdard University. He is a renowned scientist. He has received many awards in recognition of his contributions in diabetic research. He has published 150 research papers and a few chapters in international books. I welcome Dr. Sab. The
Kunal.
title of his talk is Prevention of Diabetes and Other NCDs Through Faith-Based Leaders.
Bismillah ar-Rahman ar-Rahim. Madam Chairperson, thank you for the kind introduction. And please allow me to thank the organizers, especially Professor Iqbal Chaudhary, for this kind invitation. The topic that I'm speaking may sound a bit odd for this conference, but I think it fits in very well because this is a hybrid conference. The diabetes, you know, there's an epidemic. The epidemic throughout the world. But what people don't appreciate that this epidemic is rising faster in developing countries like Pakistan, Bangladesh, India, these places. In developed countries, they have reached a sort of plateau. In this background, this epidemic is mainly due to type 2 diabetes, and which is largely preventable. I'm very thankful to the today's morning session's chief guest who mentioned about this prevention, see, and he emphasized this about this, and my talk is about this prevention. You know, the diabetes was first recognized as epidemic by the International Diabetic Federation in 1990. Then subsequently by WHO. But in 2006, it was raised to the United Nations. And I dare say it was raised to the United Nations. It started with a letter from me to the Foreign Minister of Bangladesh to raise it to the United Nations. And then it was unanimously passed. And from 2007, it is being observed as a UN Day for Diabetes to create awareness that every country should take, every organization in every country should take prevention programs. Here you can see the UN resolution. 14 November was chosen the date. The reason is 14 November is the birth date of Frederick Benting, who was able to first isolate insulin from dog's pancreas. But to many people, it seems like a piece of paper. This is not, you see. It is a real call from the United Nations to raise awareness, to take action, you see. And you can see it has invited the UN Secretary General has invited all member states, relevant organizations of the United Nations system, and other international organizations to observe the World Diabetes Day in an appropriate manner in order to raise public awareness for the prevention and care of diabetes. You see. So it's not a simple piece of paper. So it's an imperative that every country should take this. As I said, this. And I said the pandemic is mainly type 2 diabetes. I shall not go through the detail, just some figures showing that 1 in 9, now 1 in 8 in Bangladesh, now 1 in 7 becoming diabetic every day. Same in Pakistan. But the cause for that, if we want to prevent it, we have to have an idea the cause for it. So diabetes is a combination of genetic factors and environmental factors. Here I'm just giving an example. The seed is the genetic factor and soil is the environmental factor. So even if you have the gene, without gene you will not have diabetes. But then it will not, if you have the seed, it will not grow the tree unless you plant it. Exactly like that. Here you can see the coconut, and then unless you plant it, you don't become a coconut tree. You see? That's this. But here I'm raising another issue. You see, according to Darwin's theory, Darwin and Wallace's theory, you see, that all defective genes should gradually weeded out. But diabetic gene is not getting weeded out. And diabetic gene is really genes, not a single gene. Many, many genes together. And theoretically, philosophically, diabetic gene in little dose without having diabetes may give survival advantages. Just I'm showing an example. In the same jungle, the leopard and deer live. But the take-up speed of a leopard is 95 miles per hour. And its maximum speed, it can go up to 150 miles. And take-up speed of a deer is not more than 15 miles and can't go more than 35 miles. So theoretically, the deer should be, the leopard should be able to catch all the deers, but it cannot. Because unless it can close the gap within 5 minutes, it cannot, because the leopard will tire out. But the deer can run in that like for not minutes, for hours. So survival is also dependent on endurance. So when we were hunter-gatherer, then having a little bit of gene might have given some advantages. So the gene will survive. So we cannot, theoretically, you can modify it. Like for single gene disease, like thalassemia, it has been really been cleared from cypress, but not genes like this. So we have to play with the environmental factors. So now, for pathway to diabetes is actually insulin resistance. What we inherit genetically is mainly insulin resistance. Now, type 2 diabetes develops when he has inherited insulin resistance, but his insulin secreting capacity, maximum capacity, is not high. So he cannot compensate by raising insulin production. So that will cause diabetes. Now, all the factors for prevention are not known, but we know for sure the lifestyle modifications and chemo prevention can play a big role for prevention, and these are evidence-based. But these are showing many studies. I shall not go through more with this. And this prevention is highly cost-effective. You can see this study was from India. I showed the different methods, but these are the cost, highly cost-effective, because having diabetes 1 year will cost more than that. Now, as I said, the UN resolution is to take national policy. Bangladesh has taken a proposed national policy, although it has not been adopted by the government. But here you can see these many factors. The factors that we have identified, this is from Diabetic Association of Bangladesh, identified are not, has no implication on budget. It's a political consideration, political will, like prevent malnutrition in pregnant mothers, like while you give award, let's say award for Phil, you also consider his contribution to prevention. So that's just one point, like that. Involvement with religious institution, yes. And that's the national policy. In Bangladesh, we have taken, trying to tackle it from many different angles. Like we have tried to educate the public through folk singers, especially composed folk songs played in places of gathering. So this, and screening in workplaces like in factories, and then educating people. And there we found the prevalence of pre-diabetes is also quite high. At the moment, Bangladesh has got about 138, 1.38 million people with diabetes. 1.38 crore. But equal number have got pre-diabetes. So you can think of the number. And Bangladesh is a country where diabetes has got a very strong presence. So more than about 70.7 million in Bangladesh are 7 million, sorry, in Bangladesh have come under treatment. So half is not under treatment, and half doesn't know that they have diabetes. So that is the background. So these are factories workers. So we have done intervention study, and diabetes prevention intervention studies we have shown that lifestyle modification, metformin, lifestyle plus metformin, gliclazide, lifestyle modification plus gliclazide, they all have effect. But these are resorting to call to study situation. That's not real life. Situation. Now, the several methods that we have tried, which has got a huge impact, you see. We found that participatory learning cycle. We tried this first in reducing maternal and neonatal mortality. The basically thing is that if people gather together, discuss their problem, find out solution, and try to implement it themselves, and try to modify as they go. And then we tried this for diabetes, and we found in rural areas, this has got a big effect. These are now published studies. You can see these figures that also we have tried mobile messaging. And in mobile messaging, the way we gave it, we found it has created awareness, but it has not shown any result in the outcome. Maybe then we have to give more messages like that. So, and then this is the technology, said mobile messaging. Now the question is, medical community as a whole would say that we are trying to motivate people, but people simply don't listen. But is it true? Think of tobacco industry. Tobacco, who doesn't know that smoking is harmful? Is there anybody here who doesn't know smoking is harmful? Not only that, I believe many of you might have taken one puff in your life. And it's very unpleasant to start with. But the cigarette company is still able to recruit smokers. And see the method they have used. You know, this is on the left, advertised through Ronald Reagan. This middle picture is the picture from the Absent-Minded Professor, a Walt Disney movie. See, in that picture, you'll find that the professor who invents something, and whenever he's in problem, he lights a cigarette. And then on your extreme right is linked with Romance. And the one below, he is the most popular Bengali hero in cinema ever produced. Bengali cinema in Kolkata got Taliwad, and that's Uttam Kumar. So whenever you see, like smartness, they linked all these. So we thought, could we try other means? And you will know and you will agree that Islam has got strong message about good health, how to maintain good health. And the messages are very, very strong. They're like a message saying that a good Muslim would not eat to full stomach, should not eat more than 1/3 of the stomach, like that. Even Prophet said to his wife that you are all the time saying, have food, have food. With full stomach, your prayer may not be accepted by God. Very, very strong message. We thought, can we use the religious leaders to give this message? So we thought to identify religious leaders, we identified mosque imams. Because in the mosque, there is a Friday prayer, and there the imam gives a sermon, what we call khutbah. In reality, the khutbah is supposed to be his speech. That he says at this time what a good Muslim should do. So we discussed with them, with their association, are they prepared to say this? Because this is an epidemic, and a good Muslim should try to prevent epidemic, and they have they can play a powerful role. So we recruited 100 mosques. And that's the period when the study was done. So we organized a training program for the mosque imam about healthy lifestyle, etc., religious code. We recruited about 10 highly learned Muslim scholars from Dhaka and said, you please compose a khutbah which will, according to the religious text, not his khutbah, it's quoting the religious text, who is the dean. And we also use the mosque as Baptist corners, the corners, because that's where people come for prayer and then they can get some message. So these are the training programs we did now. In Bangladesh, also I think in Pakistan, ladies don't go to the mosque that much. So we recruited their family members, imam family members, train them so they can spread the message among these. So first we did in 100 mosques and we found it has a very, very big effect. So subsequently, we thought to make it a highly scientific publication, we thought we'll do a control study. Control study means 150 mosques will be under this program and 50 would be separate or no under program. And so that is really summer. But anyhow, and after this study, we found it has produced a very big effect, more than 45% lowering of diabetes incidence in 1 year. 1 year. It has reduced some also in control area because control areas are far away from the experimental area, but still there has been some overflow of information, but very, very highly significant. And then this was circulated, this khutbah was circulated in the OIC member states. So also we sent it to Pakistan also. In fact, before we spread this, we sent it to Al-Azhar. See, because in Sunni Muslim community, Al-Azhar's fatwa is taken somewhat official. So they authenticated that this is correct according to the text. Then we sent it to the Grand Mufti of Kaaba, and he also authenticated it. And see that this corner. Then we tried to make it a self-sustaining project, self-sustaining project. Because what I'm saying now may sound a bit controversial, but still I'm going to say. Then in Islam, there is no official priesthood. And a person is not supposed to extort money for leading a prayer. But in the mosque, we thought the mosque imams can be trained for primary care of life. And in that way, they can spread the message, they can give primary treatment, etc., etc., and also can earn a little bit of money by honest way. See, and it clicked. That's the khutbah. And through this process, the imams can earn about $100 a month. So that correction. So I'll quickly go through it. So that's the. Then subsequently, we thought, why not try to other religions, other religions. Here, I must say, I presented this data about 2 years back. This has been published in JAMA, Journal of American Medicine. It is going to be a good impact factor. You see. In fact, I would like to say, I'm not mentioning it. I sent it to another journal in UK. And they commented this highly relevant study, very good study, but not suitable for their journal. I believe that it was done through Muslim imams, so that's why they thought it would be very sensitive for them. But JAMA accepted. When I presented this in London University, they were very interested about it. But they said our people have no faith in religion. We said faith-based leaders. Your people have no faith in religion, but they have faith in something. They have faith in beyond God. You find out people, leader on whom your people have worked, and try to spread the message. We have in Bangladesh, we are now planning to try with other religious leaders. It so happened in Bangladesh has got a cardinal. Because for the first time in the history of papacy, a Bengali has become a cardinal. And I'm fortunate that we studied in the same school. And he calls me like an elder brother because he was junior to me in the school. So I took his help and have a discussion with the bishops and archbishop, and they said they will do it. But not much written in their religion. And then we, with the Sanatana, which is normally called Hindu, the Ramakrishna Mission, went to the pagoda, the Buddhists, and they also have said that they will do it. I'll go through it. So survey this. I'll just show you the data. I'll keep enough time so that you can discuss, and if you have got queries to do it. So I just so that it has affected all aspects of NCD. Diabetes has gone down, incidence rate of diabetes has gone down. The hypertension has gone down, obesity has gone down, and people's behavior about exercise, diet, they all improved. So that's the Jamas network where it was published. The details of the study are shown. You can see the cumulative incidence rate. Just show you, because this will be with you. So if anybody is interested, you can go through it. It's changing its factors show big effect. So I would like to conclude that the prevention of diabetes is feasible. But we have to find out the right language and right medium. And unfortunately, I dare say the scientists are not giving attention to this aspect of it. The tobacco industry are giving it. The food industries are giving it. What will motivate people? What language will motivate people? They spend money and experiment, and then they say. But we are lagging behind. So if we have to be successful, I think we have to compete with them and find out the right language. We have just one language, but many other languages. So take-home message will be, every society places trust on their leaders. It is essential to identify those who can positively influence their conversations. Not only direct lecture by the physician or doctor saying that you modify your lifestyle, you will do it. But human being has got a tendency that, well, whatever happens, I will escape. Otherwise, people could not go to a battle. So Islam carries a strong message prompting healthy lifestyle. Our initiative engaged Imam recognize the profound social and spiritual. No? With that, I'll stop. Thank you very much.
Thank you very much for your wonderful and insightful research. Now the floor is open for questions and answers if we have.
Well, I must say one thing. If a speaker gives a talk, if there's no question, it means either of the two things, either one of them. Everybody has understood everything. Or otherwise, we haven't listened. We don't care. So you choose.
Yes, yes.
Thank you for that. Okay, thank you for that wonderful, wonderful presentation. I just wanted to make a little comment. You showed that lovely photograph of a cat chasing a deer. Now that cat was not a leopard, it was actually a cheetah. It was a cheetah, not a leopard. It was a cheetah, not a leopard, chasing the deer.
I I showed this.
It actually doesn't make
I
any
made
difference.
this slide. I made this slide
Yeah.
just to convey the message that endurance is also a very important factor for survival, let's say. So if a gene, like you see, thalassemia, many of you would know that thalassemia gene survives because it gives advantage, survival advantage against malaria. And at one time, malaria was endemic throughout the world, and the thalassemics survived better, let's say. So that gave a survival advantage. Although thalassemic, what you call homozygous thalassemic, they would, in those days, hardly attain adulthood. So this is genetic advantage of different things. So when we are hunter-gatherer, how long we could hunt, that had a bearing on our survival. So maybe if you have a little bit of diabetic without having diabetes, then we maintain our blood glucose better. It will not go below. So they will not tire out so easily. So it might keep survival advantage. So saying that if we want to attempt to eliminate diabetic gene, we should not be successful. We have to concentrate on environmental factors.
Thank you very much, sir. The truly fascinating is you always bring novel ideas. Listen to your lectures, and every time gives you so much, thought to ponder. And certainly, what we have as a model of our Prophet, peace be upon him, is it's just amazing that we have a role model for us whose life was such a balanced life, such a natural life. And that you have used this strategy to conduct a study which is evidence-based, published in a very reputed journal. I just want to ask you a bit off track that we also have, in case of diabetes and other chronic disorders, a lot of misinformation. It's called infodemic, There is so much of misinformation that, for instance, people keep using a lot of non-validated herbs, non-validated other stuffs, and they literally kill themselves, because they think they would be treated, they are treating diabetes. And as a result of it, this become a major menace because instead of taking evidence-based, natural or synthetic medicine, they've been using all these agents without any evidence. And this is all misinformation which is spread through social media. How to encounter that? How to encounter misinformation? Because before you provide right information, you need to encounter misinformation.
If I have understood your question properly, first I must say I requested you to listen to the lecture. I have got a purpose for it. I think the prevalence of diabetes is getting astronomically high in affluent Muslim countries. And here is a way where we can really make a break. I see. So I thought that if I say it in front of the comstech-oic Coordinator General, I see, if you take up a program in Pakistan to spread the message, in these OIC countries, and then we might be able to be successful in this. So that is the main reason why I requested you to be present. I believe that it is possible. The country where diabetes incidence prevalence became very high was Finland. But they have been able to correct it. But Finnish society is very small number, highly affluent, and everybody's life is more or less what you call coordinated. You see. So that their method would not be applicable for countries like ours. You see. So, I don't know whether I have answered you.
Thank you very much.
Thank
Thank you. Now our next speaker is Professor Begum Ruqayya. She is a distinguished pharmacologist specialized in anti-diabetic research and natural products. She currently serves as Dean of Basic Sciences at Bangladesh University of Health Sciences, Dhaka. With over 35 years of academic and research experience in pharmacological evaluation of medicinal plants and natural products for the management of diabetes in both animal model and clinical settings. Professor Ruqayya has published over 90 peer-reviewed articles, many book chapters, and other papers with more than 3,400 citations and an H index of 26. Welcome, madam. Today's topic is medicinal plants in the treatment of diabetes and its complications, local use, and scientific evidence.
Thank you, Madam Chairperson, for your kind introduction. Ladies and gentlemen, Assalamu alaikum and very good morning. So, from today, we are from early morning, from the inaugural session, we are talking about diabetes and its complications, etc. So, my topic is related to that as well. So, I have these contents. I'm not going to repeat reading, but it will be on my top. So, ladies and gentlemen, we know that diabetes has become one of the most challenging public health problems of the 21st century. And despite the great strides that have been taken to understand the disease-related complications are increasing unabated. So, we see that the number of diabetic population is increasing globally. So there is a 45%. So high. There will be a 45% increase in the number of diabetic subjects in the year 2050. What is much more dangerous that the people from the Southeast Asian region where we reside, there we will have 73% of increase in the diabetic population. So as I told, why it is increasing in such a epidemic way, because we have changed our lifestyle. We don't walk, we use cars or buses. We have changed our lifestyle, food habit in that we used to take fast food, and we think that this is luxury when we go out and take McDonald's burger or KFC or fried chickens. We love to eat that. And we don't want to cook at the kitchen. So ready-made you can get from Food Panda in Bangladesh, and you can have those junk foods, and also less activities, physical activities. So these are the traditional medicine and current opportunities, starting from the acupuncture and Unani or medicine. There is a big use, and from the right side, current trends and preferences in herbal medicines are that there is herbal tea as well. So we have worked on herbal tea. I will, at the end of my lecture, I'll be focusing on that. So this is not the correct slide you have given. Not the correct slide. Anyway. This is the, yeah, today, because my today's it that was previous, because, yeah, this is the previous one that I gave lecture. Yeah.
This one?
Yes, yes, because those data are from previous lecture from, okay. Okay, yeah. Yeah, I will start from here. Okay. Okay, I mean, I can make it. Okay, thank you so much. Okay. Today morning, we've been listening to the health minister of Pakistan. He was saying that every 4% in Pakistan has diabetes. The picture is always like in Bangladesh. We have every 7% has got diabetes. And this told data that 8.4 million people have diabetes and another 8.4 million people have pre-diabetes, which means that either they have impaired fasting glucose or they have impaired glucose tolerance, or some people have both IGT and IFG together. And it has been stated that Bangladesh will be among the top 10 countries globally and poses a considerable burden to individuals, families, communities, and society. And of course, this will have major implications with respect to healthcare needs and costs. So this is the, we know that that I have told that there are so many people will have diabetes by the year 2050. Majority of these diabetic population will be type 2 diabetic, not type 1. So type 2 diabetes actually resembles defect in many features. If we speak about the omnious octet, this omnious octet actually refers the 8 pathophysiological abnormalities that we can find in diabetes. Actually, this interplays the interaction of insulin resistance together with the beta cell secretory defect with other 6 abnormalities. It may be, there may be in diabetes, there type 2 diabetes, there may be increased glucagon secretion from the alpha cells of the pancreas. There may be hepatic glucose production rate. There may be neurotransmitter dysfunction, which means people to eat more. There may be decreased glucose uptake. There may be increased glucose reabsorption, and there may be increased lipolysis and decreased incretin effect. So if we don't give attention to these 8 pathological abnormalities, we cannot treat type 2 diabetes properly. Merely just addressing hyperglycemia will not give you the proper treatment modalities. So we have, in the inaugural session, I said we have insulin secretagogues like sulfonylureas. We have insulin sensitizers like metformin. Metformin is the drug which is actually being taken by the people all over the world for so many times, and it has been originated from plant Galega officinalis. We know that, and we have insulin mimetics like GLP-1. And we have DPP-4 inhibitors and also alpha glucosidase inhibitors. And also nowadays we have sodium glucose cotransporter 2 inhibitors, etc. But as I told, they have so many complications or so many adverse effects. For example, sulfonylurea, they actually have primary failure. Then the metformin, then you need to increase after 2-3 years of the same dose. You cannot be your glucose level will not be the same if you don't increase the dose. Then incretin mimetics, the GLP-1 analog, they have to be taken in injectable form, and they are costly. Then there are so many complications. So therefore, we need to search for new therapies, new therapeutic modalities to treat diabetes. So many common herbs and spices that claim to have blood sugar lowering properties that make them useful for people with diabetes or at high risk like IGT or IFT people. A number of clinical studies have been carried out in recent years that show potential links between herbal therapies and improved blood glucose control, which has led to an increase in people with diabetes using these more natural ingredients to help manage their condition. Actually, people think that natural remedies are natural, so they don't have any toxicities or adverse effects. This is not true because until and unless you actually validate them with scientific experimentation, you cannot say they have no toxicity. So we need to clarify that. So, since this is a very crucial problem, the diabetes epidemic, so we started our working together, Burden and Dhaka University together. At the same time, the work has been taken together in the BMC Medical Cell Biology Department of Uppsala University, Sweden, and also Mahidol University in Thailand. So this started in the year 1991, and then when UNREP formed in 1995, we started more vigorously because we had got the grant or from financial support from IPEX, International Program in the Chemical Sciences. So we started working on animal models of diabetes. We prepared type 1 diabetes and type 2 diabetes. We know that type 2 diabetes is much more prevalent. And to make this model is also difficult. People are using too many models, like high fructose and high fat fed diabetic model. But we are exercising another different model, which is called neonatal type 2 diabetes, where we actually inject intraperitoneally streptozotocin, a beta cell toxic agent, to only 48 hours old pup. And when they become adult at the age of 12 to 14 weeks, we then give them oral challenge with glucose to see whether they cope up the glucose load. And then we actually take them as diabetic. So we actually, to screen only a single plant, we take 3 models of rats. One is normal, one is type 1, and one is type 2. For type 1, it is much more, we know that for type 1 patient, he needs to get insulin from outside, otherwise he can survive. But for type 2, it's much more complicated because I say there are diverse abnormalities in multiple tissues. So for that, we actually work on 3 model rats at 3-prandial state. Why 3-prandial state? Because we know that at fasting state, your glucose level may be not always it is the same. But at postprandially after taking food, you may not have the same glucose level. If a diabetic, basically type 2 diabetic, because they have lost their fast phase of insulin secretion. So when a diabetic eats food, his glucose level shoots very high. And there is no fasting insulin secretion, fast phase of insulin secretion is destroyed. So working on 3 models actually give us an idea when we need to give this plant material and how maybe it may shed some light. What is the probable mechanism of action of the plant material that is lowering blood glucose level? So to screen only a single plant material, we need to actually use 3 multiplied by 3, 9 series of experiments. So it is really I'm not saying that it's an exclusive methodology, but I'm saying that it is fairly exhaustive. So using these methodologies, more than 90, now it's 100 plants have been screened out in Bangladesh, and the plants that we got through UNREP activities, not only from Bangladesh, we screen plants. We screen plants from Bangladesh, from Pakistan, from Balochistan. Dr. Rehana Rashid from Balochistan, she was an UNREP fellow in Bangladesh, and she brought some plant from Balochistan. Then we had fellows from Karachi. Too many fellows had been working over there. Then we had fellows from Nepal. We had fellows from Kolkata. And beyond Asia, we had fellows from Cameroon. Dr. Celestine Sokin, he also brought some plans to screen this on diabetic animal model. So doing the screening results, it gave us a list of plants which actually lower blood glucose level, but we at the same time, by analyzing the models, by analyzing the grandial states when it showed activity, we could make a group of those plants that those are working on lowering glucose levels. So we got some plants that actually lowers glucose level, improves insulin secretion, and we got some plant, a very few, one plant that is called Gymnema silvestre. That plant actually showed beta cell regeneration activity. So, so if it actually works on beta cell regeneration, so it clicks to our mind that it might be helpful for type 1 diabetic patients. So like that, we got some plants which actually delay carbohydrate metabolism in the intestine. It is very important methodology to lower glucose level, because if a diabetic eats some food, his or her glucose level should. But if we can find some plant material that actually absorbs the glucose, but not very quickly, it actually tries to, if the glucose is absorbed very quickly, there will be very sharp blood glucose rise. But if it absorbs the glucose gradually, then the curve of the glucose level will be much more normalized, not high peak. Because high peak of glucose is not good for cells, not good for, they may serve as culprit for diabetic complications. So we got some plants which actually delay carbohydrate absorption in the gut, and we also know that there is a relation between dyslipidemia and diabetes. So we actually, when we tested the animal models of diabetes in a chronic model, that means we fed them force feeding for days together, like 28 days, 56 days, like that. We found that these, some of the plant materials actually lowers atherogenic lipids, which actually not good for health, and improves HDL content. And we also tested their antioxidant property. And based on these results, we compiled a Bangla book, Bengali book, where we actually given the data, given the information of those plants from how they work on animal model. And since these plants are edible, so we recommend people that these people can take these plants in, we said diabetic people as well as IGT patients can take that. Those in a way, we say that before meal, after meal, like that, because analyzing the data postprandial and fasting condition. So the first book we published, it was in 2012, and 10,000 books we published, and we disseminated throughout the country. And then we again published another book in 2020. The number of plants here we have increased, and that where we incorporated the data of 57 edible plants. So this is a work from my one of my PhD students from the northern part of Bangladesh. These are the two plants, Chlorindrum infantulatum. Local name is Vat, and its English name is Vati. And another plant is Foria cordifolia. Local name Bulancho. English name hot leaf. These two plants are being taken by the people as traditional, that they lower glucose levels. So, and they're taking randomly. without any scientific evidence, without any actually experimental results. So this PhD student came to our lab. He was a chemist, biochemist, and according to this scheme, we actually tested these two plants. There were three extracts: wort extract, methanol, and chloroform extract. And we have tested acute experimentation, and also we tested for chronic 28 days study. And there were some chemical works, and we actually I'm coming to what we did. So chronic experiment of this of different extracts of clerodendrum infantillatum and phenospora cordifolia on fasting serum glucose level of type 2 diabetic model rats. Here we can see it was actually comparable to glibenclamide. This is an diabetic controlled rat, and in here we can see the ethanol extract of clerodendrum infantillatum actually showed the significant result. So there was chemical investigation of different extracts, PLC of this chloroform extract of PI, that is clerodendrum infantillatum. We can see 5 fractions over here, and this is the PLC of ethanol extract of chloropenton infantillatum. Here we can see F1, F2, F3, and F4 fractions. And these are the RF values detected components of clerodendrum infantillatum. So these F1, F2, F3, F4, and we actually, with when we work on in vivo, we found that serum glucose level lowered. So we worked on pancreatic perfusion techniques with these compounds. So this is a very tedious experiment. Nearly 250 sutures need to do on the pancreas to take off the pancreas in a viable state. And then you have to pass through the solutions through the inlet tubing, and you have to collect those in the fraction collector override. And then you have to measure insulin content over this powerful gauge. So we found that all the fractions we have tested on pancreatic perfusion experimentation, the F1 fraction was good for serum glucose secretion. We know that 3 millimolar glucose is a basal concentration. It actually is not a stimulant for insulin secretion. But when we added this fraction to the 3 millimolar glucose in the perfusion, we found that insulin secretion was high, significantly. And also at 11 millimolar glucose, the insulin secretion was high. So among these 5 fractions, this fraction was actually much more effective in insulin secretion. So fraction 1 shared the highest insulinotropic effect in comparison with other fractions. The structural studies were done in Japan. So this study indicated that it was a 5-15. This is chlorophyll-like compound. It's structured 1H and 1,715 NMR mass spectra. So we think that the obtained hypoglycemic result is possibly due to this 5-5 of clerodendrum infantillatum. And in 2023, we actually published this, our findings in South African Journal of Botany. So I now discuss about the recent elucidation of anti-diabetic property of some locally claimed plant materials in our lab. So there are a number of plants that we recently worked. This is Dilena indica. Then we have the rhizos sinensis. We have Punica granatum, we have the Beta vulgaris and Clerodendra and C mutans. So this is the methodology that we followed for this experimentation. We actually, as I told that to make type 2 diabetes, we inject 48 hours old rat, and after they become at the age of 14 or 12 weeks, we have to make an oral glucose challenge. 500 milligram glucose load we have to give them orally, and then we have to collect the blood at 0 minute, 30 minutes, 19 minutes, and 120 minutes to see how they work. How they differ from the normal. rat glucose, because whenever if they become diabetes by that insult that we took them on the age of 2 by injecting tryptozotocin, they actually destroy the pancreatic beta cells, but not all the pancreatic beta cells die. The remaining beta cells try to cope up with glucose that we give them at the age of 12 or 14 weeks. So we can find that their glucose level a little bit is higher compared to the normal rats. If the normal rat have fasting blood glucose 5 to 6 millimole per liter, these type 2 diabetic rat will have fasting glucose level a little bit higher, maybe from 9 to 11 millimole. And when you are challenging them with glucose load, their glucose level will be much more higher than the control rats. If you give the controllers the same amount of glucose, the rise will be 3 or 4 millimole per liter. But if they are type 2, they become type 2, the glucose challenge, they can't cope up that glucose load, and you will get a very high glucose level starting from 15 millimole or above. And after 2 hours, it won't come to the normal level because they are they have some insult and their pancreas cannot cope up the glucose load. So this is the schematic diagram that we work with these plants. So we have some phytochemical assessment, and we have in vivo testing on glucose level, on lipid profile, and we have also molecular biological testing. So I'm going in details if you are fair. So this is the fruit, the Alinea indica. Bangla name is chalta, and English name is elephant apple. I don't know whether it is found in Pakistan, but in Bangladesh it is available, and people are consuming it as fat lowering, because many people said, "Oh, my TG level was very high, so I took soup, means dal soup with this chalta, and my glucose level lower." So we keep in mind, we tested this chalta because an edible plant. So we this plant fruit, and we make water extract of this, and we went for the phytochemical screening, and we found that it has got alkaloid. It has got flavonoids, terpenoids, and phenol, and saponin. And when we performed the DPPH antioxidant activity, we found that it has got a significant DPPH antioxidant activity compared to the standard ascorbic acid. So since people are taking as lipid lowering, so we made this type 2 rats also dyslipidemic. We gave them high cholesterol and fructose, and for 15 days we gave them, and they become hyperlipidemic by they become fatty, and they become, when we tested their glucose level, we found that they have got dyslipidemia, and we tested the extract on the model. So we find that the model rats, they have become, their body weight is increasing significantly. So when we tested their fasting glucose level, there are 0 day value that is left side and right side there at the end of the experimentation. There we can find normal control, diabetic systematic control, then glycemic and methanol extract of Alinea indica. We found that these 2 methanol extract has got so high, I can't show. Anyway, you can see, I think, from your side. So we found that they actually lowered fasting glucose, and insulin level also significantly increased, but there was a significant lowering down of the insulin level in diabetic dyslipidemic control rats. So we took the data, and we actually worked out to find the HOMA B, that is beta cell secretory function, and also HOMA S, that is insulin sensitivity, and also HOMA IR, HOMA insulin resistance, by using HOMA sigma software. And we found that Dilena, methanol extract of Dilena indica actually increase beta cell secretory effect, increase the beta cell function on 28 day. Also, there was the insulin sensitivity was increased and it significantly increased the HOMA-IR. And since our target was that the people are taking as dyslipidemic, so we went for taking, seeing that how it works on serum lipids. And we found that effect of this Dilena, methanol extract of Dilena indica on lipid profile. We found that TG level decreased significantly. And then we found that LDL lowered and cholesterol level lowered significantly. So again, we actually went to see the TG to HDL ratio and total cholesterol to HDL ratio. And we found that both of these indicators were decreased significantly in treatment group. This is AST and the right side is the ALT. These are the indicator of liver function tests. So we also went to see whether what's happening with the liver function test when we are feeding them for 20 consecutive 28 days that are with these extract, and we found that there was no alteration. There was even significant lower down LT and AST. So it says that liver function is not hampered by using this extract. Then we also went to see the thawed superoxide dismutase level. We know that this is a rate limiting enzyme and actually accelerates because of self oxidation, free oxidation radical is removed. So we found that thawed superoxide dismutase level was compared to 0-day value, there was decreased, but it was very good in GT group. So we went to see the level of CYP 7A1. This is the enzyme cholesterol 7 alpha hydroxylase, late limiting enzyme for cholesterol and bile acid synthesis. So we wanted to see why, what is happening with this enzyme, and we found that in this CYPL level by the influence of methanol extract of Dilena indica, they increased significantly. So we made the conclusion that methanol extract of Dilena indica is a source of a few group of phytochemicals, although the phytochemicals were not so high, but it might be effective in reducing the glycemic and lipidemic status in diabetic associated dyslipidemia. That's the possible reason behind these effects might be increased beta cell secretory function, because we found that HOMA-B was improved, leading to a higher insulin, higher serum insulin concentrations, improving insulin sensitivity and ameliorating insulin resistance. Therefore, the CYP7 gene function in the liver cell is increased due to the improvement of insulinemic status in the systemic circulation and is responsible for regulating lipidemic status in diabetic associated dyslipidemia rats. So next plant is Ras chinensis meal, and this is another one was Cinnamomum tamala. These two plants we got from our underfellow from Nepal. These two plants we have, but those two MS students from Nepal, from the Bhubaneswar chemistry department of Bhubaneswar University came to our lab as an underfellow to work on this. So we tested those in our lab. Chemically, we found that phytochemical, the alkaloids represent flavonoid, then steroid, saponins and tannins were present there, and they have As formic acid, when we did the evaluation of antioxidant activity of our chinensis and Sitamalum birds, methanol extract by DPPH method, we find that they are really good, have got good IC50 value, and they have the antioxidant capacity. So this is the result for 90% methanol extract of Ras chinensis and Sitamala. Serum glucose level and of type 2 diabetic rats. As we can see that compared to baseline value, they have got significant glucose lowering effect. And also serum insulin level increased significantly. Okay, serum superoxide dismutase level, it was high, and serum MDA level, MDA is an enzyme that is rate limiting enzyme for the conversion of free radicals. So MDA level actually raised was found to be lower, so it is good for health. So we found that serum MDA level decreased. So we also went to see the total antioxidant capacity of these rats by the influence of these two plants. And we found that total antioxidant capacity found to be raised, although not significantly, but it has been found to be raised compared to diabetic control. So we went to see the level of GLUT4, GLUT4 is stands for facilitates the transport of glucose into the cells. So we wanted to see the what happens with glucose transporter, and we find that glucose transport expression of glucose transporter was 1/10 was raised compared to the diabetic control, and they were but it rose in Chinese Sitamama group, but not so high as Ras chinensis group. So our conclusion was that 90% methanolic extract of our chinensis groups and Sitamala but significantly improved glycemic status in type 2 diabetic rats by increasing GLUT4 activity through insulin-regulated glucose uptake in adipose tissue. Additionally, the phytochemical constituents of these plants may be responsible for high antioxidant capacity, reducing oxidative stress through increased superoxide dismutase and total antioxidant capacity levels, and decrease malondialdehyde levels, and thus mitigate the oxidative damage of pancreatic beta cells and enhance cell performances for insulin secretion, because the insulin level was found to be raised. So another plant is Punica granatum. I think you have already, it is can be found in local name is Italy, Omegrante in English name, and beetroot. Okay, we always find in the tables. Beetroot is good for health, you should know, and good for diabetes as well. So we tested these. So antioxidant was phytochemicals was FB, and so our we found that significantly decreased their ethanolic extract and wheat vulgaris used on the body weight. Their body weight not their body weight was not significantly improved or decreased. So regarding fasting blood glucose levels, we found that both Beta vulgaris and Palmita granatum, they actually lowered serum glucose level. So this is stands for serum TG and triglyceride level, and since there is a correlation between dyslipidemia and RDT, so we also always go for, when we clinically feed those experiments, we always go for checking the serum lipid profile, and we found that diabetes dyslipidemic control compared to type 2 diabetes, their lipid profile improved. It means atherogenic lipids decreased, and the received, and yeah, we can see LDL, HDL increase to the right panel. LDL decrease significantly, but HDL is a good lipid increase significantly. We also see the relative CYP cholesterol 7 alpha hydroxylase activity, and we found that expression of this gene was increased in P granatum and B vulgaris level. So our conclusion was that the ethanolic excerpts of 80% ethanolic excerpts of P granatum leaf and beta vulgaris root pulp extract reduce glycemic and lipidemic status in type 2 diabetic rat with dyslipidemia. Both extracts have the potential to upregulate the expression of the CYP7A1 gene in liver tissue, which is the possible molecular mechanism underlying this effect. So another plant, this is Sina consatinitans. Actually, this plant I brought from Malaysia, and I planted it in our BUHS campus. So this is a very good plant, and I say that we have a garden of Sina. This is really a good plant, and it actually shows very good effect. And one of our we have a tomorrow we have a oral presentation of this. So I'm not going to read this all. So the conclusion I may just read out. Our findings suggest that C. nutans leaf aqueous extract is rich in phytochemicals and exhibits significant antioxidant activity, which may contribute to improved glycemic and lipid profile in type 2 diabetic rat. The potential molecular mechanism underlying these effects involve the upregulation of the insulin receptor IR and glucose transporter type 4, GLUT4 gene expression in adipose tissue and skeletal muscle following treatment with C. nutans, leaf aqueous extract. So now I'll be talking on the development of a herbal tea from edible plants. If you go through the literature, you can find that Camellia sinensis is good for health. They lower they lower fasting glucose because it is rich in polyphenols, rich in epicatechins like etc. And you can find that there is literature statement like that. They can inhibit DPP4 activity. So since we had tested a huge number of plants, so we thought that why not to make a cocktail of the plants for a herbal tea. So we took these 12 plants and we made a tea. So these are the plants that we took for the preparation. All of these are edible plants, and all of these plants have glucose lowering activity, and we have screened all of them. So we made a herbal tea of this and prepared tea, and okay, we actually went through also measuring the elasticity of the individual animals as well, because we go to give prescribe give for people. Maybe we can go for commercialization in our mind. So we individually go for measurement of elasticity, preclinical work we had done before, and then we went to make this tea, and there was a combination. We spent considerable time to get the color, if it is a good color, if it has some aroma. By combining all these together, sometimes you have not good taste. The taste is not good. So we have spent a considerable time to make a good combination of these herbal tea, and we had the trial, pilot study on our students, almost 300 students, including us, the teachers, compared to those we are aged people, but we took this tea, and we gave our opinion regarding the taste, regarding the odor, regarding the feeling. So when we analyze the results from the students' response and from the teachers' response, we found that majority of these, they say that this is good test. Some made notification that, oh, you should put some lemon over there, but we said that there is there is a plant which contains that. And some said that add some flavor, add some, many people like that too. So we made a statistic and we try to improve, and we would like to do this trial on type 2 diabetic people. And keeping in mind that it won't harm people because it has been tested on animal models, and all of these are edible plants. People are selling tea. I don't know in your country or in Asian country, you can get so many people are commercializing tea, herbal tea. I don't know whether they have done the rudimentary scientific evaluation about those plants they have kept. But in our lab, we have very exhaustive way we have made this, and we hope to make a clinical trial on type 2 diabetes. Because one thing we need to mention over here that if you add sugar or artificial sweeteners to this, that may not work, because we are giving people this type of tea just to say that you will be feeling good. If we find in type 2 diabetic people the glucose level lower, then we can say that your glucose level will lower down. And if we get that there is a significant lowering of glucose level having this tea, then we can go for, we have an idea in our head, we can go for commercializing this tea. So this is concluding remarks that type 2 diabetes is a disease of enormous consequences to the health and wealth of modern and developing societies. All avenues must be explored to provide the most efficacious and safe medicines for the long-term therapy of this chronic condition. Here we have presented some role of plant-based natural products with their beneficial properties in animal models of diabetes as an evidence of anti-diabetic agent that might be helpful to develop new drugs for the treatment of type 2 diabetes and its complications. So I must acknowledge our sponsors, EPICS, International Program in the Chemical Sciences, IFS, International Foundation for Sciences, ANDRA, Diabetic Association of Bangladesh, Bangladesh University of Health Sciences, and Dhaka University. And I'd like to introduce my co-workers whom we work, and these are all our mentors and co-workers. You can see Professor Azad Khan over there. He is always with us, and he came also from Bangladesh to join this seminar. And you can see Professor Mrs. Zaman, Professor Liaquat Ali, and Professor Nilufar Nahar. I think you know all of them. And this is Professor Shainul Haq Khan. He is our deputy network leader of UNRWA. Because in the year 2018, when I presented the application for grant to the EPICS, they made that every network has to be a network leader and deputy network leader. So I became the network leader, and Professor Shainul Haq Khan became the deputy network leader. And Dr. Mohammad Farooq, he is now, I think, proctor of the government university. He was with us, but he has joined on government university, Joshua Science and Technology University. And Dr. Runju is with us. And you can see Mehdi Hassan Tushar with her name is Bordal. She is a fellow from Nepal, working in our lab with Mehdi Hassan Tushar. And Mehdi Hassan Tushar is now working his PhD at the University of Lahore. You can see him here. And they're working in the lab. There are so many people who are working there. And our hands-on training workshop, we always invite people from other countries, but it is now expensive because we cannot afford the plane fare. But whenever the fellows come to work with the MSc students, PhD, we help them to work in our labs. We just ask or request them to bring the plant material, raw plant material, and then the chemical work goes to the chemical lab, and then a biological experiment. We have our own animal house. Oh, I forgot to mention that we had been starting our work in Badam. Then we had been shifted to Bangladesh University of Health Sciences. It has been also established by Bangladesh Diabetes Committee, and this is a part of this Bangladesh Diabetes Committee. And I have left Badam with my and came to Bangladesh University of Health Sciences with my own animal house. So we have our own animal house where we can work the biological activities, and we have our own chemistry department where we can chemical work can be taken. So this is that's it. And this thank you for your patient hearing, and I'm at your disposal. Thank you.
Thank you very much, Professor, for the excellent and very informative presentation. And we really appreciate your great contribution in the field. Now the talk is open for questions.
Thank you, madam, for your very informative and comprehensive lecture. I'm Dr. Abata, professor in pharmacy, representing University of Sawabi.
Can you
hear me?
a bit loud?
Can you hear me?
Yes, I can.
Thank you very much for your very comprehensive lecture. You have conducted the activities on the crude extract, and you know that in crude extract there are so many activities involved, like potentiation, addition, and synergistic effect.
Yeah.
The second, that most of the crude extract are associated with so many toxicities. So I think it will be better to go for the isolation and purified compound and establish its activity on the basis of the lethal dose, toxic dose, and effective dose. So we will just know the actual therapeutic window of these compounds. And my second question is about the potential mechanism involved in glucose lowering, whether it was due to alpha amylase inhibition or alpha glucosidase inhibition, or it was due to antioxidant potential. I will suggest that in University of Sawabi, we have a very rich flora. So we are also working on nutraceutical and plant extracts. So it will be better to go for signing an MOU between the Dhaka University and the University of Sawabi. Thank you.
Thank you very much for your nice comment. Yes, you are very right that crude extract contains so many things in it, and some of them may show synergistic activity, or some of them might be antagonistic. But when you are doing an in vivo experimentation and you are getting a glucose lowering effect, so we can assume that there is something that actually works. So next step is to go for bioassay guided fractionation, and you can go for the chemical work, and you have to pinpoint which one is actually responsible for this. So I think we need to go for chemical assays a little bit more. We have to do rigorous chemical experimentation. So we think to do that. The second part also, I appreciate your comment that what you say. So in future activity, we can go for that. One difficult thing is that we are stuck out with the spectral analysis. We cannot identify because we have NMR, LCMS, MS in Dhaka University and also in BCSIR. But whenever we have to request on payment basis, they can, but majority of the time they are occupied with their own work, so there is a queue on that. But still now, but still then we feel it's important to go for that. Otherwise, truthful effect of confusion you cannot make. Thank you.
Thank you very much, Mrs. Rukia, for always presenting your extremely focused and hard work. Uh, I was wondering about the prevention which we have discussed this morning, because as we have seen from the presentation of Professor Azad Khan, that before someone develop a full diabetic symptom, he or she has go through a impaired glucose tolerance called pre-diabetic. And apparently there is not so much research interest. I think this is the stage where we can prevent a full-fledged development of diabetes. What is your take on it, and how can we work on that particular phase of metabolic disorder?
Yes, thank you very much, Professor Iqbal Chaudhry. I was listening to Professor Azad's sir's lecture. The minister from your health, he was also mentioning that prevention is better than cure. Yeah, we know that. So at this stage, you are absolutely correct that we can have just diagnosing people who have IGT or IFG impaired. They're just on the eve of having full-blown diabetes. We can, through these plants, they are some working. So we can go for giving them, if they are edible, means people are taking evidence they have taking it for a long time. So you can skip the toxicity testing and you can go for giving those people and see what is happening for a longer time, whether their IGT or IFG level stays on that, or they can develop type 2 diabetes. Because one thing we need to emphasize that not only drugs will help you to prevent, but the lifestyle modification. You have to tell all the people that lifestyle modification is very much important. If you don't follow the diet, if you don't, you are eating junk food, you are not following, and you're taking the medication, it won't work. So if we can give people at the same time, we need to tell them that of course you need to follow the lifestyle modification, exercise, and food habit you have to follow as it is described for diabetic subjects. And I think at this stage we can go for prescribing them.
I am Dr. Mdeha Lodi from University of Lahore. I just want to ask, have you checked the effect of any of the plant from herbal tea on type 3C diabetes, as it is also relevant to pancreas because of the pancreatic cancer or pancreatitis? So have you checked the effect of any of the plant on type 3C diabetes or other hyperglycemic condition because of the other hormones like acromegalic diabetes, adrenal diabetes, gestational diabetes?
Yeah.
Have you checked that?
Oh, yeah, thank you very much for your question. No, we didn't go for this type C diabetes. And for gestational diabetes, we won't we can't do that, because the pregnant lady will never go for testing. Yeah, but what we can do, we can make pregnant rats, pregnant animals can go for testing. This can be done, but not for, we have never done, because we had classic type 1 and type 2 diabetes, we have been practicing.
On type 1 diabetes.
Yeah,
their
one
autoimmune
plant.
disorder
Yeah, one
and
plant
all.
that we found is this throughout our journey. That was Gymnema sylvestra. That we found that it helps to regenerate pancreatic beta cells.
So
in
when
type
we
1.
talk about the type 3C diabetes, in
Mhm.
that case, pancreatic cells also destroy,
By
but that is because of the cancer.
okay.
And if we use this plant in that case,
Okay, they
so-
may regenerate. Okay, I understand. Thank you.
Thank you very much, Madam.
Okay, thank you.
Today's third speaker is Dr. Nisar Ahmed. He's reader in clinical biochemistry, Department of Life Sciences, Manchester, Metropolitan University, UK. He received the British Muslim Award in 2014 for services to science and engineering and was a top scientist author for the journal Diabetes Research and Clinical Practice. His research interests include protein glycation in diabetic complications, identification of nutraceuticals. He is the author of over 100 publications, and this includes 10 best-selling textbooks used worldwide on biomedical science programs. I welcome you, Dr. Her title today is Anti-Glycation Properties of Momordica carentia, Possible Role in Management of Diabetic Wound Healing.
Okay, good afternoon, everybody. Assalamu alaikum. First of all, I'd like to thank the organizing committee, in particular, my dear friend, Professor Iqbal Chowdhury, for inviting me here. This is the first time I'm coming to Comstech, and it's a real pleasure to be here. I've come all the way from Manchester, believed to be the second city in the UK, although if you meet someone from Birmingham, they'll probably disagree with this fact. But, you know, I'm from Manchester, and I'm sure you all know about Manchester. Yes, it's the home of Manchester United. They used to be very good at one time. They're not so good now. But we also have a second team called Manchester City, and they are really, really good. So I work at this university called Manchester Metropolitan University, one of the largest universities in the UK. We have two big universities in Manchester. And as you can see here, these are some of our students in the library. They are all students of today. They dress very smartly. They all have an expensive, mobile phone. When I was in college, students used to look very different, okay? This is what they used to look like in the 80s, almost as if they're from a different planet. I'm sure Dr. Iqbal can relate to this. Okay, here is our building, new building, science and engineering. We moved into this last year. It is really, really nice. And we love visitors at our university. So if you happen to be near Manchester, please do come and visit us. Here is a very eminent professor from Pakistan who is visiting our university. And here he is with me in the Trafford Center. We're having an intellectual discussion. Who can drink more milkshake? Okay, so I'm going to talk about this fruit called Momordica carentia. It's also known as bitter melon or bitter gourd. I'm sure you're all familiar with it as karela. And there's been a lot of work done on this fruit in relation to its effects on blood sugar levels. That's fairly well established. I'm going to talk about something more different, looking at its anti-glycation properties and how it might be of use in diabetic wound healing. So diabetes, people have talked about this already. The biggest issue in diabetes is high blood sugar. So a lot of the problems that people with diabetes have is because of this hyperglycemia. And diabetes is a global problem. I was at the IDF World Diabetes Congress in April, and the latest figures are this. 589 million people with diabetes in the year 2024. And we can expect 853 million people in 2050. So it's a global problem. It's a huge, huge health issue. Look at the different countries, top 10 countries, and the number of diabetics expected in 2030. Pakistan is there in the top 5, as you can see. And all those countries in red are countries where they typically use traditional medication, like Momordica carentia, for managing diabetes.
Diabetes was responsible for 3.4 million deaths in 2024. And these deaths are largely because of chronic complications that people with diabetes have. I'll say more about those in a minute. So there's increased risk of these chronic complications with poor glycemic control, which is why it's so important for people with diabetes to manage their blood sugar levels. Because if you don't, you will develop one or more of these complications, and they will cause morbidity and mortality. They will either disable you or they will kill you. And if you look at these complications, the damage is largely to blood vessels. These can be large blood vessels, macrovascular, or small blood vessels, microvascular. Here are some of the diabetic complications. The macrovascular ones: stroke, heart disease, hypertension, peripheral vascular disease, foot problems. Microvascular ones: diabetic eye disease, renal disease, neuropathy, and so on. One of the key complications of diabetes is delayed wound healing. So when they have a wound or when they undergo surgery, it takes a long time for that wound to heal. And the problem is they end up having wounds in their lower limbs. And if it's delayed wound healing, you're more likely to get infections. So these wounds can easily become infected. And the only way you can really deal with them is amputations. So unfortunately, diabetes is responsible for a lot of amputations in people. They lose their limbs, they become disabled, they can't work, and the cost to the patient, the hospital, the society is enormous. Now, I want to focus on wound healing. It's a very complicated, coordinated process. I don't want to talk about everything in detail, but it starts off with formation of a blood clot. So whenever you get a wound, the first thing that happens is you form a blood clot. And the purpose of that is to prevent further loss of blood. You then get phagocytic cells moving in, so you get traction of phagocytic cells. Another key step is formation of new blood vessels. That's known as angiogenesis. And we know that in diabetic wound healing, angiogenesis slows down. And that probably explains the delayed wound healing that you see in diabetes. And eventually you get closure of the wound. So wound healing is very important. We don't want it to be delayed, because if it's delayed, you will get bugs moving in, you'll get an infection, you'll get gangrene, and so on, that I just talked about earlier on. I want to focus on this process called angiogenesis. There's a lot of expertise in my department on angiogenesis. If you look at angiogenesis, a couple of things happen. The first thing that happens is you get proliferation of endothelial cells, and then you get migration of these cells, and finally you get tube formation, capillary-like structures. So this is something that we can look at in vitro in our laboratory to investigate angiogenesis. You can quantify cell proliferation, cell migration, and finally tube formation, all key steps, processes in angiogenesis. Okay, as I said earlier on, increased risk of complications with hyperglycemia. It depends on the degree and the duration of hyperglycemia. So the more poor your blood sugar control and the longer you've got this poor sugar control, the higher the risk of developing these complications. And what's actually happening here is sugars in your body are damaging key molecules. And this is a process called glycation. So they attach to proteins non-enzymatically. Used to be known as the Maillard reaction or Browning reaction by food chemists. I'm sure you've all cooked food and you've seen it go brown. Well, that is the Maillard reaction. That is the Browning reaction. What's happening here in this food is you're getting sugars reacting with proteins. And because you're using high temperatures, this reaction is occurring very, very quickly. And you can see the browning taking place in front of your very own eyes. In reality, the same reaction is taking place inside your body right now. Okay, it's happening inside your body, except it's happening at body temperature. It's happening much more slowly. If you're a diabetic, you will have higher levels of blood sugar, and this reaction will be increased. In terms of chemistry, this is what's happening. Free amino groups from proteins reacting with carbonyl groups from sugars, giving you shift spaces, and then finally an Amadori product, which is a stable compound. That's what glycation is. These amidori products can undergo subsequent reactions involving intermediates, and they go on to form what are called advanced glycation end products, or AGEs. Now, AGEs tend to be protein-protein crosslinks, or molecules attached to a protein. And basically, throughout life, these AGEs are accumulating on our body tissues as we age, okay? Especially in long-lived proteins, they're building up. People with diabetes have higher levels of glucose, so you will get more of these AGEs accumulating in our body tissues, in our organs, and so on. And it's now generally accepted that buildup of these AGEs are responsible for the long-term complications that people with diabetes have. So this is one AGE. This is a cross-link between two proteins. It's called pentosidine. It's one of the first ones that was identified. This is the second one called pyrroline. So it's a chemical group attached to a protein. It's not a cross-link. Indeed, we've identified about 30 different types of AGEs. And it's not just glucose, which is the culprit and taking part in glycation. There are other sugars that take part in glycation. One of them is called methyl glyoxal. It's a very reactive dicarbonyl compound. It can be produced from glucose, and it's a side product of metabolic pathways, and its concentrations in diabetes are increased. You get about 300 nanomoles per liter in diabetic blood, compared to about 100 nanomoles per liter in normal blood. And it can react with proteins and make these AGEs about 300 times faster than glucose. If you look at AGEs, sources can be endogenous. They can accumulate inside our bodies. They can form inside our cells, accumulate in growth factors, nucleic acids, in the blood and serum proteins, structural proteins. But they can even come from outside the body and enter our body. So a lot of the food that we eat is nowadays rich in AGEs. Okay, a lot of the processed food. Apparently, the AGEs give the food the good taste. So we like to eat more of that food, and we end up taking in a lot of AGEs. Some of these AGEs are lost in the urine and in the gut and so on, but some end up in our blood and get deposited in our tissues, right? And the foods that are really bad in this regards are the typical junk foods that we shouldn't really be eating, but we all do eat. Okay, McDonald's, Kentucky's, and so on. And the other thing is we can get AGEs entering our body from cigarette smoke. So cigarette smoke has substances like nornicotine, which can glycate our proteins and make AGEs. It also has reactive dicarbonyl compounds, methyl glyoxal. All of those can make AGEs. In fact, we know for sure that people who smoke have higher levels of AGEs in their blood than non-smokers. And smoking is a problem in the UK. A lot of youngsters, a lot of university students hang around outside the university over lunchtime, and you can see them smoking. You'll even find some professors hanging around and smoking as well if you tend to visit the Manchester Metropolitan. But smoking is bad news. Okay, harmful effects of AGEs. Why are they harmful in the first place? Well, they can cause protein-protein cross-linking. They can decrease ligand binding. They can modify protein half-life. They can alter protein immunogenicity. So essentially, you're changing the structure of a protein. You might cause its cross-linking. There might be groups attached to it. If you change its structure, you're changing its function. So that's one way they cause damage in our bodies. But the other way they cause damage is that during the glycation process, you actually generate reactive molecules called free radicals. So for example, look at the glycation reaction there. Glucose plus protein giving you Schiff-based amidori products that can go on to make AGEs. In the presence of oxygen and transition metals, the glucose can undergo autooxidation and produce free radicals. The amidori products, okay, can also undergo autooxidation and generate free radicals. The advanced glycation end products have receptors in our body, and they can interact with those receptors. And when that happens, oxidative stress is generated, free radicals are generated. And of course, these free radicals are atoms or molecules with an unpaired electron. The most common one being oxygen. You know, when it loses its electron, it's called a superoxide radical. It's very, very reactive. and they damage proteins, lipids, nucleic acids, and cells. So glycation AGE formation is accompanied by generation of these highly reactive free radicals which damage biomolecules. Another thing that happens is that in our bodies, our cells have receptors for AGE, and these receptors are called RAGE, okay, receptor for advanced glycation end products. And AGEs will interact with these receptors to generate oxidative stress and promote inflammatory reaction. Okay, and we know that inflammatory reaction underlie a lot of the complications that people with diabetes have. There's a lot of interest in preventing glycation, preventing the formation of these AGEs. There is interest in compounds that are protein competitors, you know, that will bind to proteins, prevent them from going on to make AGEs, or bind with sugar, prevent them from taking part in the glycation reactions, or interact with amidori products, preventing them from going on to make AGEs. Antioxidants, okay, because AGE formation requires oxidation. Transition metal chelators have a role as well. There's interest in compounds that can react, that can trap reactive dicarbonyl species. A lot of interest in age crosslink breakers, the RAGE blockers, prevent AGEs from interacting with the RAGE, and then RAGE signal transduction inhibitors. So a lot of interest in various pharmacological substances and natural substances. In our laboratory, we became interested in this plant, Metabolic acrantia. Here is a fruit, and people eat this. They can eat the outer flesh, the green bit, or the inner yellow bit with seed, which is called the pulp. So they eat either a Metabolic acrantia flesh, the pulp, or they eat both. If you're very, very brave, you might make, juice of Metabolic acrantia. I knew a professor who did this. It's not easy to drink. I can warn you about that right now. Okay, it's very, very bitter in taste. You've got to be really brave to drink a glass of this Metabolic acrantia juice. And believe it or not, there are tablets available for Metabolic acrantia. You can buy them in Pakistan, okay, from all sorts of places. You can even get bitter gourd juice, to buy. So a lot of interest in Metabolic acrantia. And if you look at the scientific literature, there are things that we know about Metabolic acrantia. It's been shown to improve insulin secretion. It's been shown to lower blood glucose. So these are scientific findings. And that has been attributed to polypeptide P or carnitine. So there are substances inside Metabolic acrantia which help you to achieve these things. And in fact, there's been quite a few clinical studies with varying results. Most of these studies have shown that Metabolic acrantia will lower your blood sugar levels. Some of them haven't, but most of them have. But the other interesting thing is that Metabolic acrantia in liquid gel form has been shown to promote wound healing, diabetic wound healing, in animal models, in rats, in mice, in rabbits. If you apply it topically, it enhances wound healing, which we mentioned earlier on. So it's got a particular beneficial property. The problem is nobody really knows why that happens. And we've tried to answer that question in the study that I will talk about now. So one of the questions we asked ourselves was, does Metabolic acrantia affect formation of these so-called advanced glycation end products? So we did some very nice studies, in vitro studies. We took a model protein like albumin, incubated it with methyl dioxazole to make AGEs, and then we included extracts of Metabolic acrantia, so that's Metabolic acrantia pulp, Metabolic acrantia flesh, and then the potential active ingredient, carnitine, which we obtained in a pure form. And for the angiogenesis studies, we used bovine aortic endothelial cells. These are excellent model cells for looking at angiogenesis in vitro. So we looked at the effect of Metabolic acrantia on formation of AGE. Have a look at the gel. You've got a marker there. You've got the protein there on its own. And if you look at lane B, you've got the protein incubated with methyl glyoxal. And you can see the dimers, trimers, and tetramers, and so on. And that is the AGE causing the cross-linking of the protein. But then look at lane C, D, and E, where you've got increasing concentration of mammalic acrantia flesh, and it has an inhibitory effect. So basically, mammalic acrantia flesh will inhibit formation of advanced glycation-free products. We demonstrated a similar effect with the pulp as well as the carantine. Okay, so essentially, mammalic acrantia is inhibiting formation of advanced glycation and products. We decided to have a look at mammalic acrantia and its effects on angiogenesis of endothelial cells. So the first thing we did was look at the effects of these extracts on proliferation of endothelial cells. What are the key steps in angiogenesis? So you've got initial seeding there, you've got the control. We used a positive control called FGF2, and as you can see, proliferation increases significantly over a period of 72 hours. But then look at the extracts at 3 different concentrations, 10, 50, 75 micrograms per milliliter. All of them enhance proliferation. So mammalic acrantia extract enhancing proliferation of endothelial cells. We then looked at migration of endothelial cells. That's the distance migrating as well as the number of cells migrating. And we used a wound healing assay. So we had a monolayer of cells, we created a wound, and then looked at their migration from the wound. And again, look at the first slide, that's the control. Look at the slide 2, that is the effects of our positive control, FGF2. So, you know, a lot of migration. And then look at 3, 4, and 5, where you've got the different extracts of mammalic acrantia. And again, these extracts are enhancing migration of endothelial cells. And finally, the third aspect we looked at was tube formation, okay? Again, as you can see from the experiments there that we've done, the mammalic acrantia extracts all enhance tube formation. So essentially, in vitro, what we're showing is that the extracts, as well as the carantine, are enhancing angiogenesis, a key step in wound healing. Angiogenesis, remember, is delayed in diabetic wound healing, and is probably responsible for the delayed healing that you see in diabetes. We then wondered whether the mammalic acrantia extracts affected intracellular signaling in our endothelial cells. So we looked at expression of phosphorylated ERK1 and phosphorylated ERK2. So these are signal transduction molecules associated with angiogenesis. And what we found, again, was the positive control, FGF2, increased expression, but we found increased expression with mammalic acrantia pulp here in this experiment, and then with the flesh, again, similar results, and then similar results with the carantine. So there seem to be influencing intracellular signaling of PERK1, PERK2 molecules. We're seeing increased expression of these molecules inside cells. But what we're getting is a bell-shaped response. Finally, we went on and we thought, does mammalic acrantia protect against AGE-induced inhibition of angiogenesis? Our laboratory, together with a number of other laboratories, showed that AGE, advanced glycation end products, they inhibit angiogenesis. And we wanted to know whether these extracts protected against AGE-induced inhibition of angiogenesis. So we first of all looked at effects of mammalic acrantia extracts on AGE-induced inhibition of proliferation. So you got the initial seed, cell seeding, you then got the control after 72 hours, you got the positive control, FGF2, and as you can see, massive proliferation. But then when you add the sort of highest dose of AGEs, BSA AGEs, you see a reduction in proliferation. But if you include mammalic acrantia extract, pulp, flesh, and carantine, as you can see, there is enhanced proliferation. It's having a protective effect. It's overcoming the inhibitory effect of the AGEs. We repeated the same experiment looking at migration, and again, BSA AGEs inhibit migration, but the extracts have a protective effect. And the same with tube formation, AGEs inhibiting tube formation, but the extract enhancing tube formation, having a protective effect. So it seems that these extracts are protecting against AGE-induced inhibition of angiogenesis. And finally, we wondered whether the Metabolic extract, they're acting via the receptors for AGEs in endothelial cells. So what we did was we used an anti-RAGE antibody. So we pre-treated these cells with this antibody, and this antibody essentially blocks the RAGE receptor. So it's no longer working. Okay, and we also use a isotype IgG antibody, which doesn't block the RAGE receptor, but otherwise has the same characteristics as your antibody. And what we found was that when you block the RAGE receptor, the extract are not actually having an effect, and there's no increase in PIR1 and PIR2 expression. And similarly, when you block the receptors, AGEs are not having an effect as well. And what that means is that the Metabolic extract are acting via the RAGE receptor. So just summarizing our findings, Metabolic extracts we showed for the first time inhibit formation of advanced glycation end products. We've shown that they promote angiogenesis of endothelial cells, which is a good thing, because if you promote angiogenesis, you will enhance diabetic wound healing. They also protect against AGE-induced inhibition of angiogenesis in endothelial cells. So AGEs, as shown by our group and other groups, inhibit angiogenesis, but extracts have a protective effect. And we've shown for the first time that they can act via this RAGE receptor to alter intracellular signaling. And of course, that means that they have therapeutic potential. So in conclusion, foods like Metabolic may protect against diabetic wound healing. This was an in vitro study, and there's a need for more human studies in the future to actually be able to demonstrate this effect. Maybe we need to reconsider the dietary advice we provide to diabetic patients. Maybe they should be eating more healthy foods like Metabolic. And, I like this saying here, let food be thy medicine and medicine be thy food. So healthy food is important for a healthy life. So maybe we should be taking in more of Metabolic as part of our diet. So healthy food for a healthy life. And of course, you need to have a healthy lifestyle for a healthy body. So if you look like this gentleman here, he's not very healthy, as you can see, he's overweight. Change your lifestyle and you might end up looking like this. Okay, so think about that seriously. So this is my group in Manchester Metropolitan University. It's much smaller now, but Dr. Ali Al-Johi, my PhD student, he's gone back to Saudi Arabia. He did all this work. He doesn't talk to me anymore. He's done very well for himself in Saudi Arabia. Dr. Sabine Matou Nasri was a postdoc from France, and I think she's moved over to UAE, married a rich Arab, and moved abroad. Dr. Dongri Liu is there, and my colleague, Professor Mark Slevin, who is an international authority on angiogenesis, and he helped with all the angiogenesis work. And finally, thank you for listening to me. You've been a wonderful, wonderful audience. Okay, I didn't see any of you sleeping.
Thank you very much, Doctor, for your great insightful presentation. I have a question.
Okay, fire away.
Who can drink this bitter drink?
Nobody, oh my God.
I don't know for question.
I think I had 2 questions about your part 20.
I can't hear you, I'm afraid, sorry. Shout.
Actually, I have 2 points about your part 20. What about that upstream signaling cascade of ER to 1/2 population? Second one is, what about the negative?
Let's go back to the first question.
Yeah.
So you're asking about the signaling.
Yeah.
Okay. I mean, the signaling is fairly complex, but we just looked at phosphorylated ERK1 and 2, because if you look at most studies, they are the ones that tend to be associated with angiogenesis. Okay, I'm sure there are other molecules as well, and we have in other papers done much more extensive signaling, but the data I've just showed is for the phosphorylated ERK1 and 2. because this is preliminary data, okay? So we just decided to look at that to keep it simple, okay? That's the answer to your first question. What's your second question?
So actually related the signaling system. Actually, I want to know the negative feedback of ERK phosphorylations, especially for USP5. What's the role of USP5 against your ERK 1/2 phosphorylation?
Okay, I didn't quite follow your question, okay, but it's probably one that I can't answer. But maybe I can have a chat with you later on. Is that okay?
Yeah, thank you, sir. Thank
Over
you.
lunch. Okay. I'm hoping they serve in Kerala in lunch. Okay. I know you're all hungry. Okay, it's lunchtime. Yeah.
I have a quick question.
Oh no, she's gonna ask me a difficult question. I can see it coming.
Actually, I was thinking, you have mentioned the extract
Yeah.
of this fruit. So, and you were showing a juice of that fruit. So, have you checked the juice, or is there the extract is ethanolic extract, I believe,
Yes.
right? And this juice that human will drink will be water extract.
Yeah.
So, have you checked these two?
No, we haven't. We used extracts of the flesh, you know, the green bit outside, and then we used extract of the pulp, and then we used, you know, carantin as well. I would imagine that what's actually happening here is because we're dealing with extracts, you're getting synergistic effects, okay? And that's probably what, you know, an element of that probably happening inside here, because these extracts are rich in antioxidants and so on. As far as the pure juice is concerned, no, we haven't tested that. Does that answer your question?
Yeah.
Yeah.
All right. So do you think that the effect would be the same, or maybe there are some changes?
It's difficult to say. I would imagine there would still be some sort of effect because we're seeing it both with the pulp and the flesh. So I would imagine you would see the effect with the pure juice itself. But then to go on and actually identify the active ingredient, although we did show that carantin had a significant effect. But there are probably other compounds there which are having an effect as well. And this is, I think, is always the difficulty with this type of work when you're dealing with extract, you know, trying to identify an active ingredient, the ultimate active ingredient. I would imagine in all likelihood, there's probably more than one. Okay?
Thank you. Thank you.
Thank you very much for your nice presentation. I'm Dr. Sadia Naseem from Comstech University. I'm really wondering if you are having any idea if the topical treatment of the extracts are having any role in the wound healing?
They do, yes. This has been demonstrated by several studies where they've used Momordica, Crantia, cream, gel, etc. They've always been in animal studies, as far as I know, in rats, mice, and in rabbits. And nearly in all of them, the Momordica Crantia enhances diabetic wound healing, okay? But there's very little information there. That is something that is seen, but there's very little information on the possible mechanism, which is what we are trying to answer. Okay?
I have one question. Can I ask? Oh,
Yeah.
it was a very good lecture, but I wanted to know whether you can tell from your experimentation in which stage of formation of AGE this product can work, because we know when protein and sugar bind, there is shift by and then there is anaerobic product, and then the carbonized.
Okay.
Which stage you can get the effect?
Okay. It's difficult to say, but we can actually do it, okay, experimentally. And there are ways of doing it, and I have done it for other compounds. It could be that they're stopping the first part, you know, the synthesis of the amidori product. That step is called glycation. More likely, what's happening here is it's in the subsequent steps, which require oxidation when you're making these advanced glycation on products. Okay? You know, some compounds can act, they behave as antioxidants, and they prevent the formation of these AGE from amidori products. There are some compounds which act at multiple sites. There are others that act at just one site. So, for example, aspirin, good old drug aspirin, can inhibit glycation. And what it does, it acetylates the protein and prevents it from being glycated. And so if you remember that figure that I showed, there's multiple steps where a potential drug could actually act. And there's no reason why it can't act more than once.
Whether if you could know it starts earlier than.
You are quite right. Okay, there is so much that needs to be done. But I'm becoming an old man, and I can't do everything. Okay, so we will maybe get onto that at a later stage.
Thank you very much.
It's a pleasure.
And with this, we
Assalamualaikum.
conclude the session. Okay, we have one. You can ask at the lunchtime because we are getting late. Thank you so much.
Everybody's hungry now. They want to go for lunch, including me.
I'm thankful to all the speakers for taking time from the busy schedule and for traveling all the way from different countries. And I'm thankful to all of you for your participation. Thank you very much.
Okay, welcome back, ladies and gentlemen. We are beginning the second session of our event here. So the second session will be chaired by Professor Dr. Begum Ruqayyah, who is the network leader, Secretary General of ANREP, and also serving as a dean at Bangladesh University of Health Sciences. Please welcome Dr. Ruqayyah on the stage, please. Okay. So, madam, should I invite the speaker? Okay.
Good afternoon, everyone, and welcome back to the session again. The second session, we have three speakers. First speaker is Professor Dr. Roshan Zamir. He's the Associate Professor, Department of Chemistry, University of Rajshahi. Second is Professor Dr. Vijay Kumar. He's also here, Professor Emeritus, Department of Chemistry, University of Radenia, Sri Lanka. And the third speaker is Dr. Mohammad Ranju Ahmed, Associate Professor, Department of Chemistry, Bangladesh University of Health Sciences, Dhaka, Bangladesh. May I now call upon the first speaker? The CV. The CV of the speaker. Is there? I didn't find the CV of the speakers. Okay, otherwise they will start without. May I call upon the first speaker, Dr. Roshan Zamir. Dr. Roshan Zamir is the Associate Professor of Department of Chemistry, University of Rajshahi. He had his PhD in natural product, and he's now working with also herbal medicine. So the floor is yours, Dr. Roshan Zamir.
PM, 3 February 2019, Mirpur, Kustia, Bangladesh. Mr. Ayub Ali and his daughter Shamima and her friend Noor, they are watching television as a regular evening. They all are suffering from cough. That's why Ayub Ali went outside and bought a cough syrup. After taking the syrup, Shamima became very severe sick and went to hospital. She died. In the meantime, The rest of them are become sick, and Nur Muhammad also died, went to hospital, and Ayobali got admitted in the hospital. This is the medicine, herbal medicine, cough syrup, marigold. There was a huge cover, news coverage. Interesting. If you still now, if this that drug which is registered by the Director General of Drug Administration, DGDA, and you can get easily in the market. This raise the concern regarding regulatory system and health science. So failure to the strict control, the potential toxic drugs allow to remain available to the people with potential risks. So Dr. Roshan Jamir, Associate Professor, Department of Chemistry, I would like to thank Chair for giving me the opportunity to deliver our research. And I would like, I will talk little bit different than plant material. I will talk about herbal drugs, whether it is safe or not. So, safety challenge of herbal medicine in Bangladesh, contamination, adulteration, and toxicity. Let's begin in setting the context. All of you know that Bangladesh is a densely populated country in the world. We are facing the severe challenge in healthcare system. Only 3% of DGP is spent on healthcare services. And the professionals, healthcare professionals, very short. Only 7 doctors and approximately 1 nurse per 10,000 people available. That is very, makes a complicated the healthcare delivery. And out-of-pocket expenses account for 30% of the total health expenditure is used for our healthcare, and it's proved that people turn to the percent of people turn to the complementary medicines, including herbal medicines. Nowadays, Bangladesh experienced the rapid growth in herbal market. Besides that, 33% of patients in Dhaka chooses alternative medicines. Herbal medicines are part of the plant material, which is processed various ways and treated different type of diseases like reproductive health disorder, gastrointestinal diseases, respiratory diseases, cancer, skin, etc. And people think that it is safe. 68% people think that it is safe and affordable, and it is easy to get. So people are using the herbal medicine. So the following categories of herbal medicine are used in our country: energy stimulating libido drugs, gastrointestinal medicines, respiratory medicines, inflammatory and pain-related drugs, skin disorder medicines, and diabetic medicines. And the producer use the attractive or lucrative advertisement of that. But raw material storage in dirty place without ventilation and temperature control, finished formulation storage without maintaining proper storage condition as well. And drug manufacturing company producing this without proper sanitation. Two products are produced without cleaning the equipment. And all of the herbal market, if you see, the people are selling without proper authorization. So this brings us to the biggest question that we must address. Are the herbal medicine safe? There is plenty of international and national reports that prove that there is a morbidity, comorbidity, and sort of regulatory system and safety assessment as well. And what do the experts say? The FDA and NHS, they suggest us not to use the herbal medicines because they have toxic effect, and they put importance to for ensuring the safety of the herbal medicine and yes. So how do we require safety assessment? Potential contamination like heavy metal toxicity, microbial contaminants, pesticides, chemical adulteration, among toxic concern, maybe organ damage, drug-drug interaction, standardization issue, adulteration and substitution side effects, and lack of regulatory oversight. Our primary goal is to ensure the safety, addressing some key point. And do we assess synthetic drug adulteration, preservative level, heavy metal presentation, presence quantification, assessment of acute and subacute toxicity in mice model, hepatotoxicity, nephrotoxicity, parameters, evaluation in mice model, and evaluation of in vitro toxicity like genotoxicity among microbial contaminants and microbial contaminants. Drug adulteration was analyzed by high performance liquid chromatography. We see the presence of toxic metal and adulteration, different type of adulteration, which is active ingredient in pharmaceutical, preservative level using UV or HPLC as well, and metal concentration using AAS, ICP, MS, and XRF. In our first phase of in vitro experiment, mice was grouping with the gradient dose of low with high, and we receiving their food 1 and 2 days, and we observed the acute toxicity, saying mortality, change of physiological activities. And after that, we receiving them the food regularly and until 28 days, and we see the subacute toxicity, change in observing body weight and kidney weight and general health condition. So, and the second phase of in vivo experimental experiments, we grouped the mice into several group, normal group, paracetamol group for hepatotoxicity, and gentamicin group for renal toxicity, and standard group, and our treatment groups at various doses. And the blood serum was collected at 29 days, and the kidney function marker are analyzed, and also histopathological work done for different toxicity observation. In vitro toxicity, we follow the tripanglutide exclusion method. Microbial contaminants was done by culture-based method. Genotoxicity in Allium cepa was done for genotoxicity and genotoxicity and to so the results in our adulteration assessment through HPLC, basic adulteration, adulterated herbal antidiabetic herbal medicines tested against 8 API, and all of them are adulterated with more than one synthetic drug. And this is the threat for us, because if you have diabetics and there is an undeclared allopathic drug that is become it's cause for hypoglycemia. So this is the adulteration chart graph, and we also 55 energy stimulating herbal medicines tested against 5 APIs, and presence of this 4 API in 6 to 44 herbal medicines. I mean, almost 100% samples are adulterated with this API. We have analyzed the toxic metal, and we found that there are some metal lie above the safety limit, which is said by World Health Organization. After that, by theoretical process, we evaluate. We see the carcinogenic effect, non-carcinogenic and carcinogenic, and also incremental lifetime cancer risk. Well, and I think this is the agreement for different instrument we have used, and we have assessed the preservative, which is commonly used: sodium benzoate, potassium sorbate, and methyl benzene. All are in between the safe limit, but inconsistency is found. This is the, some data for microbial assessment. All are the same, but in case of some sample, there are the level of was found to be high than safety limit, and after analyzing test, 2 potentially hazardous energy stimulating herbal drugs are selected for further biological experiment. Nishad Silver and Nordex, which are being sold in the market, claiming the safe or effective. So we have see the potential cytotoxicity compared to the crystalline sulfate, but we found the moderate, the lower of the low toxicity from crystalline sulfate with the both, Nishat silver and Narvex. Cytotoxicity was we also measured the C15, IC15 value, and we got the high. It's that there is a no cytotoxicity found. And for aquatic toxicity, no mortality, normal genetic activity is found that indicate high safety margin in aquatic exposure. And in case of aquatic toxicity, gradual body weight decrease by elevation of an NS dose and body weight decrease in two highest NV, Narvex and Nishat doses. Gradual organ index increase by the evaluation of the NS dose and organ index increase in two high dose. That is, indicate that it has mild stress in subaqueous toxicity. Now serum biochemical assays. So we focused on the liver function marker like ALT, AST, and APT. Higher dose of Nishat silver, NX3X, NS3X lead to mild hepatic stress. Higher dose of Nishat silver and Narvex showed closeness to the sildenafil liver function parameter, which is known as the very hepatic effect drug. And biochemical assay for kidney function marker, we observe urea, BAN, blood urea, nitrogen, and creatinine. Higher dose of Nishat silver led to the mild renal distress. Higher dose of the Nishat silver showed closeness to the sildenafil kidney function parameters. Serum biochemical assays also done, saying metabolic and nutritional markers like total protein, albumin, and triglyceride, and total bilirubin. Nishat silver mildly impaired triglyceride level and bilirubin clearance. Antioxidant oxidative stress also analyzed. A high dose of Nishat silver and nervous reduced catalytic activity indicating oxidative stress. And NSTX significantly increased lipid peroxidation, while nervous showed mild stress induced lipid damage at high doses. NS3X significantly impaired the GSH and GSS ratio balance, leading to oxidative stress, while nervous caused mild impairment. We also observed the gene expression, and we found the following gene the highly expressed. And histopathology for liver tissue. If you see the normal group, the cells are intact, no change. But for Nishat silver, hepatocyte degeneration was observed, cytoplasmic vacuolization, hepatocellular ballooning, so on are observed here, if you see. And for liver tissue, if you see the normal group, then there is no change. But in Nervex, for nervous cell, there is a change which indicate that mild hepatotoxicity is present. And this is the table for liver tissue histopathological. And if you see the paracetamol and gentamicin have high tissue effect. And histopathology for kidney tissue, if you see normal, there is no change, but tubular necrosis, vascular projection, and inflammatory cell infiltration, and proximal tubular degeneration, etc. is observed. And for kidney tissue, also normal tissue, no, so no change, but nervous system, nervous, there is also some changes in the muscular sense, inflammatory cell infiltration, so on. This is a table for kidney issues. And we also observe genotoxicity through LEMC per root test, and higher dose of both drugs affect the root growth number and also the cell. And genotoxicity as a LEMs.
You have 5 minutes more.
Okay, I will try to finish this. LEMC per test, and here we also found the effect. And this is LEMC per genotoxicity for nervous system. We have found the abnormality here. And genotoxicity as a LEMC per genotoxicity level was increased upon the dose increment of the both Nishat silver and nervous system. Microbial contamination total count also difference using different media, and total aerobic count and total coliforms are found high for Nishat silver, and nervous system found for salmonella count. And we also see the distinguished bacterial growth. We culture the isolate, and we found the different extent in both 1 to 5. So the Nishat silver isolate bacterial extent, and 6 to 10. So the Nishat silver. Microbial contamination test for, yes, this is the same. And we also tested the susceptibility for genetic support resistance to the antibiotic susceptibility test also done, and we found that there is some resistance for both samples. And the summary, high amount of the synthetic drug adulterant was found in anti-diabetic herbal medicines. Preservative were within limits, but inconsistent formulation observed, heavy metals contamination. Several drugs exceeded the safety limits to dangerous heavy metals like lead, mercury, arsenic, chromium, cadmium, etc. That can cause a long-term carcinogenic risk. No acquired toxicity, but gradually body weight decreases and organ index increases at a high dosage. And NS3X and NV3X showed mild hepatic stress with biochemical parameters similar to the sildenafil. High doses cause oxidative stress, cat activity, the lower the cat activity, and the lipid peroxidation and impaired GSH and GSS-G balance ratio balance. Upregulated pre-inflammatory markers like
Please go fast.
TNF alpha and NFKB, IL-6, and oxidative stress regulator, histopathological inflammatory dose-dependent liver and kidney damage, in vitro cytotoxicity, low dose dependent cytotoxicity effect observed, genotoxicity increased with dose in the onion root assay, moderate levels of coliform and salmonella detected, isolated from the resistance to 1 to 5. And overall, several drugs exceeded the safety limits at multiple tests. Their prolonged or high dose consumption may pose significant toxicological risks. Rigorous clinical trials are needed to validate safety and efficacy. People should be careful about taking herbal medicine indiscriminately. So to address these challenges, immediate intervention are needed to enforce good manufacturing practice and good storage practice. Comprehensive monitoring and stricter quality control measures must be implemented to ensure the safety and efficacy of herbal drugs. Additionally, public awareness campaign that and educational initiatives can empower consumers to make informed decision about herbal medicine use. And this is ethical permission, and I must acknowledge the International Science Program, IPS, for funding all of that. And also, I would like some PhD student, Dr. ABM Najmul Islam, Mamunur Rashid, and Ariful Islam, the MSc student, and Professor Shahid Jawar. And this is the answer, and thank you all.
Okay. Thank you, Professor Dr. Zamir, for your nice presentation. The floor is open for only one question because we are running behind the schedule. Okay.
Dr. Sami, what is the regulatory method for Ayurvedic medicine, herbal medicines in Bangladesh? I'm telling you, in Sri Lanka, you have a different body for Ayurvedic medicines, and that consists of Ayurvedic doctor, and all you submit is a formula. Which sometimes people say they don't write the real formula because it might be copied, and on the basis of that, they give permission and done. And since Ayurvedic medicine does not have immediate toxic, long-term effects are never discovered. Is that the same in Bangladesh? Approval of the drug.
In our country, if you go to the market and you went, we got several, many of herbal medicine. They are not registered. So the market and also the herbal medicine all should be monitored. And in case of toxicity, we must go for scientific evidence as well.
I think he wants to say that there are lots of herbal medicines which are being sold in the market without any registration. I am traditionally like, and I can make some herbal medicine and can sell. Who is regulating you? So there are discrepancies. So you can buy herbal medicine that has even gone any regimented. Yeah, there are, but they are,
They are,
but they're not monitoring all that, all those. That's the thing. Okay, thank you. Let us have a big hand to the speaker. Okay, let me invite our next speaker. He is Professor Vijay Kumar, and let me introduce him. I invite Professor Vijay Kumar to the podium. Professor Vijay Kumar is a Professor Emeritus and a former Dean of the University of Peradeniya, Sri Lanka, having retired as Senior Professor. He is a past President of the Science Council of Asia and the National Academy of Sciences of Sri Lanka, and has been Treasurer of the Academy during the certain period. He obtained his degree in chemistry from the University of Ceylon and doctorate from University of Oxford. He has over 70 international publications and 130 scientific communications in the fields of interest. The floor is yours, Professor Bijoy Kumar. You have 25 minutes to speak.
Okay. Thank you very much. First of all, I must thank the sponsor, Comstech, Professor Iqbal and Begum for having facilitated my coming here today to speak to you. Now, what I'm going to speak to you today has not so much of chemistry, but commercialization of research, the challenges faced in it. Now, what happened in the recent past is that commercialization is so important. You can't get a grant unless you can show that there is some chance of commercializing. And also that's going to contribute to national development. But this was not always the aim. When we started doing research in chemistry, people that are intellectual curiosity, that was more important. Now people like Siddiqui, Seshadri, Sultan Bawa, Azima Chatterjee, right? They whatever they wrote, they published. Results were in the public domain. No patenting, although I'm told that Siddiqui had about 40 patents, but I don't know whether they were actually commercialized. And Seshadri, I was told, actually died in poverty. After doing, he has got over 1,000 papers in chemistry. Ultimately, he died in poverty. So they have done very important work. Siddiqui and Chatterjee worked on raw welfare. Siddiqui also on neem, and Seshadri on vitamin. Sultan Baba studies of endemic plants. They wrote hundreds of papers, complex structures, and this they did at a time when there was few instruments, no NMR, no mass spec, and they were able to do all this. And of course, they published them. They did not look for patents. So today, of course, we have lots of pressure on us to commercialize. Now, if you want to make a commercializable product, you must have enough bioassays to showing that the extractor fraction is actually active, right? This is something where most of our countries do not have. In Bangladesh, of course, they have BERDEM, and so there is some ability to do continuous bioassays, but usually we don't have much facility. And then you have to do bioassay directed fractionation, which can be involved high throughput cleaning, cell-based assays, then molecular modeling. Then you have to isolate a compound, hopefully new one, or one with some activity, some new activity. Then you have to confirm the structure, activity, and also find out what part of that structure is responsible, structural activity relationship. And then that means more bioassays. And finally, you have to act, if in the case especially of some drugs, you have to synthesize it. When about synthesis, it's not simply just the synthesis. You have to find a method which is cheap, which uses less energy, and which has cheap raw material. So you have to, in order to do all this, you need a lot of chemicals and reagents, which most of our countries we cannot get. And finally, you have to make sure it can be manufactured. When DBI chemical engineers have to come in, and you have to pilot plants sometimes, energy costs. And ultimately, you cannot usually produce the product from our natural product. You have to make a simpler analog. These are all problems that we face in developing countries. For the structure, in order to make a cheaper and a easily synthesizable material, you have to do structure activity relationship, and also make sure that the product you get will be delivered to the reactive site properly. And once you come to then you have to come to a marketable, synthesizable active compound. This is not always possible. Now, for instance, neem, we have lots of industries based on neem, and They are based on extracts. Even Taxol, initially, cancer drug Taxol was produced from the plant. Now also is done as semi-synthetic method. Some other compound isolate from plant, which is much more readily available, is converted to Taxol. So all this involves biotechnology, and many antibiotics today are produced by fermentation technique. Ultimately, you have to do toxicity studies. Now, one of the biggest problems we have in Sri Lanka, we do not have a laboratory with the accepted accreditation to do toxicity studies. So we have to do, it's a very expensive process. Then clinical trials, which are not, in the case of pharmacological products or agriculture products, international field testing, and the clinical testing is now changed. Earlier they used to do it on animals, but now like monkeys, but now they are not, animal testing is not acceptable to society. And once finally you get this product, you have to formulate it in an acceptable formulation, which preserves the activity. And this is also a specialized field, more an art than a science. So there are lots of people have to be involved in actually producing something to which you can market. Now, also you think of intellectual property protection. You have to patent the product or the process. Process patenting, those days India used to do a lot of process patenting because they are patenting laws allowed it. But today, process patenting is not so good. It's a stronger patents if you have a product, a new product. Now, to write the products, the patent, very often scientists try to write it, but it's also a very specialized skill. You have to make claims of the product, which should be broad enough so that you can get full protection, but narrow enough because otherwise, some part of it mentions some makes a claim on something that's already done prior, the thing will fail. So and supposing you give a lecture like this on some product and try to patent it afterwards, that also will fail because you have disclosed it before you patent it. So, and developing countries like ours have very few competent patent attorneys. So most patents written in developing countries would, I think, fail in courts. But fortunately for us, most of our products, no big industries is interested. If they are interested in breaking up, if we have a really good product and a big industry is interested in breaking up our patent, it's very easily done. So expensive process also to get the patent with wide country coverage. There is a patent cooperation treaty which initial coverage for the first 30 months at low cost, after which you have to patent in different other countries. But for some odd reason, Pakistan and Bangladesh are not members of PCC. So patenting can actually cost, you got a really good patent covered in lots of countries, $100,000 to $150,000. Because you have to go to you have to appoint someone in that particular country to make the application and get it translated. So all natural product chemists, when they discover something, they think they got a big thing and they want to patent. But no good patent attorney, and patenting abroad is too expensive. So they usually patent to cover the home country, for which their funds are enough. But many of them turn out to be prestige patents that you can good for your CV and or no other purpose. But sometimes if a company wants to make your product in your country, the patent can be used to dissuade him from doing it by saying I have patent, then they will they wouldn't want to get involved in court cases. Most developing country researchers in universities are in universities and institutes, not in companies, right? That is one thing. Companies do not so much research in our country. So, but we can get a PCT patent, yes, but we find difficult. Universities and institutes find difficult to find funds to patent in, because you have to ultimately patent either in America or Europe or Japan to have a really worthwhile patent. So, and most patents do not earn money to cover the patent cost. So if If that happens in a government institution, we have problems of audit queries as well. So if you consider amount that cost to do a good patent covering several countries, it's about 5 to 10 years pay of a scientist. So they cannot afford to do it themselves. Whereas in the US, it's only 1 to 2 years pay of a scientist. So what you have to do is you have to negotiate with industry to take over the product. If the industry takes it over, then there is a very good chance that the product can be commercialized. But then developing country, in our country, we do not have industries that are willing to take that risk. And multinationals who may be interested in a product are worried that you have already disclosed it, and they also will not be coming into it unless you have started working with them earlier. But there is a lot of pressure on developing country scientists. Politicians believe that they give you about $5,000 or $10,000 grant, and that's a massive research funding, and you are supposed to produce patents. And they are always questioning why we are already writing papers. So this has sometimes affect our mindset as well, and we also want to either patent or perish. Now, most developing countries also do not have enough scientists, and more than that, do not have enough technicians. Bangladesh tried to, I don't know, it's working successfully. They were training technicians, but in our country, but when we train technicians abroad, that is, they used to, after training, they used to give to the private sector. Then after some time, they give that up and end up in countries like Barry's Australia. One of my technicians went to Australia.
Yeah.
And I lost him after training him in US.
Yes.
So also we have very little money for spend on research. India spends 0.65% of its GDP on government funds on research. Nepal 0.3, Sri Lanka 1.2, Pakistan 0.15. Where I missed Bangladesh, I think it is also 0.1 odd.
Yeah.
No, 0. Yeah. Sorry, I have a mistake here. Sri Lanka is 0.12, not 1.2.
Oh.
Sri Lanka 0.1. 0.15. So Bangladesh is also somewhere there.
No money.
And then Malaysia, Thailand gets 1%. Vietnam 0.45%. Indonesia 0.3%. As for comparison, Singapore, of course, like a developed country, 2.2%.
Oh my God.
So we have insufficient infrastructure, insufficient money, insufficient scientists, insufficient technicians, and also we do not have enough IPR expertise, marketing expertise, and still we are expected to commercialize. That is the situation that we face. So the funding that we get is enough for training scientists, but not enough to really produce IPR. The product that is often produced in developing countries, I was head of the Industry Technical Institute, is a half-baked product. It is from the laboratory product. But actually, it's after that only you have to do the R&D, that is the developing, research and developing. And this, there is no funds available. This is where the industry spends a lot of money on developing. And the administrators, politicians are unaware of it, that you need a lot for, if you spend for $5,000 on research, you spend 15,000 rupees for development. Local industry is incapable of developing a research product. So development is needed to arrive at a macro product. So much more work, and what research chemists can do is very little. IPR, legal matters, negotiation agreements, process engineering, packaging, marketing, all have to be done by others. But if you look at the US academic research, in the US also have poor returns. Less than 1/3 of patents are licensed. Even less are commercialized. Still less patents earn enough to offset the research cost. The academic research earns only about 3% of research costs worldwide. In the US, world average from R&D is only 1.57%. But when you look at the results, it's so distorted because the massive amounts have been earned by some universities in the US. So it's not an average thing. The biggest money is Google. Google was discovered by 2 students in IT in Stanford, and the patent had to go to Stanford. Ultimately, they negotiated and got the patent. They got to take over the patent, but they had to give so much shares to Google, and so Google now has at least the time when I wrote 1.8 million shares worth billions of dollars.
Oh my
So
God.
that is the most biggest money.
Yes, smart.
Then some of the other universities have got single molecules, which have made a lot of money. Emory University, 540 million. New York University, Remicade, which was over $1 billion. Northwestern University, Pregbalin, for epilepsy, 1.4 billion. Let's look at structure. It's a very simple structure related to GABA, and UCLA recently 1.14 billion. But most US universities earn less than the technology office cost the technology office. So there were alternatives like the Bayh-Dole Act, right? State funded research, IP is given back to universities. Universities are supposed to use that money, making sure that the scientists also get a part of that money. But there were a lot of controversies, few real successes. There was a big problem with the COVID vaccine. COVID vaccine was produced by universities using government money. And then the government, the American government had to pay money to the companies to buy it back. So there was some controversy about that. So, but there is a clamor for similar acts in developing countries, but I don't think it's going to be of any help. Then there's another thing is contract research. Targeted contracts, well-funded for a foreign country, institution, state or private. It is successful in India to produce vaccines earlier in pharma. Financial support for research startups, so there is in China, but this is a political thing. You can get political connection at local government level, assures scientists of startups viability. But then we are also in Sri Lanka public-private partnership, Sri Lanka Slim Tech, which started off well, but they were using too much government funds, and now it's not doing as well. Now, the consequence of from the emphasis on the IPR is that neglect of basic science may affect future development. Because science's role in improving human life now only takes place if it is profitable to the company. Potential profit decides research investment. So there are no attempt made to solve real problems facing the world. There are large areas of ignorance, and we have also ignorance of ignorance. South Asia is not a great generator of IPO. India alone gets about 6,000 patents per year. Pakistan 25, Sri Lanka 8 on average in the last 5 years. Bangladesh 5. Comparison: Malaysia 300, Thailand 150, Singapore 1,200. Malaysia incidentally has got a Motorola there. That's why they get so much there. But Thailand is a good example of country doing well. So our experience at Peradeniya, as I said, originally started with study of endemic trees. Sultan Baba, which was interested in doing a lot of secondary metabolites, no biases, equipment, UV, with only UV and IR. In the late 70s, we got a 60 megahertz NMR. Over 100 papers were published in very prestigious English journals at that time. Then we got research support at that time from IFS, IPIX, Uppsala, slight emphasis on applicability. Now we came in, we introduced bioassay guided fractionation. But what is the bioassay we had? We had only one bioassay. Started with branch stream, then we changed it to Aedes larvae, but we couldn't afford to have many bioassays. Biggest problem was the lack of meaningful bioassays. I couldn't see any solution to that. Too expensive. Now in Pakistan, they have got the Panchwani Center associated, so there is some bioassays done there, and Bangladesh has burden. But during that time, we continued writing prestigious journals. Then in 1980, I got a research grant from Sivagaigi. Our target was, of course, not in pharma, but in agriculture. Really?
Yeah.
Okay. Aedes larvae based, so we'll jump a bit and go. So anyway, Basel did a lot of range of biases, and I realize now what the industry's approach to research is. When they do NMR, they pay $1,500 for NMR to their NMR department. That type of thing, they are all based, and that is why the price of drugs are so high. So results, what are the results? We got many active compounds, few with commercial potential. First really interested one was this compound here called 14-15 epoxypyridine from Pseudocarpa campioni. It was very strong fungal activity. And then after 2 years, it abandoned because it was active in the lab, but not active in the field. So it was new when the structure was established. It was established with the help of Sibagaigi using single cell. But by the time the 2 years are up, it was published. So industry delays patenting. They want longer. The other one we had is roclagamide. It's a very interesting. We got 6 compounds, which we were patented with Sibagaigi. All these are similar structures. I have no time to go through the structures. But they report, but it was known that roclagamide reported anti-cancer activity, but we got related compounds which were broad pesticides. And these are structures, and all were related to roclagamide. And finally, they did structural studies and found out a smaller drug with bromo derivative, and Sibagaigi, which is now called Syngenta, was going to market. But ultimately, in the last field test, out of 14 places in Egypt, it became thermolabile and the project was abandoned. That's how they work. So lessons learned, easy to work with in the multinationals, no reports, no monitoring, no budgets. Funds are sent to the university, subject to university rules, but apart from that, we can use the for anything else. Contracts are given for 2 to 3 years, unless you produce results, you don't, it's not extended, but we did for 23 years. If we do not, development will be done by them, so that's a good chance, and IPR also will be done by them. We don't have to spend money. And well-constructed patents. For funds, we started with $5,000, ended up with $25,000 a year. Small money for them, but big money for us. We were able to fund any amount of students once we got that type of money. Publications were low priority for them, high priority for us. Research to patents, very success is low. Contracts are favorable to them. Royalties are very low, even if we got a product. Then we formed a local company, and this also, we had a fruit fly protein bait and a neem product. We could not interest local companies to manufacture, so we started our own company, Lanka Agro Artists, and we have 4 products: neem oil, neem cake as byproduct as well, neem oil and neem cake, and these are 2 of our products. And here the experience is financing a business. It's money, work site, equipment, employees, banks provide loans only to establish a company. Marketing is the biggest issue. Must be made available throughout farming areas. Marketing costs not sufficiently provided for. In US, they put 70% of price for marketing. We don't advertise. Pesticides, then with COVID, what happened is pesticides without approval were smuggled from India, and they are very difficult to us. And unapproved drugs are available from India. Companies still not profitable, hopefully things will improve. So alternative strategy, I think that we must think whether we really should be patenting. That is what I'm saying here. Should we be rethinking our strategies, because we should be trying to help our people's problems. Thank you very much.
Thank you, Professor Vijay Kumar, for your very informative lecture. The floor is now open for a couple of questions.
Yes.
Hello. Very good lecture, Professor. I congratulate you on this behalf.
Close to the
So
mic.
my question is, I tried to sell a patent in Azerbaijan. I have made a patent in Pakistan. I work on Muraya paniculata. So we have some preliminary studies which have a healing property. It has a wound healing properties, and we have some Blanchim tests also. So on that basis, we try to patent in Azerbaijan. Is it possible? Because, Professor, what we have studied in the literature, it has anti-HIV study also, and it has also some tumor efficacy also. So is it possible that we can, with these properties, if it has these properties in Azerbaijan, is it possible that we can patent this plant in Azerbaijan, in Russia, in other countries? Is it possible? Can you help?
I don't know whether Russia earlier did not allow patents, but now they allow, I think. But the thing is this, you can get only a process patent because of that the activity, but not the compound is a known compound. So that it's not very strong. But Azerbaijan, you can do it, but then once if somebody starts making it in Azerbaijan, you have to go to courts in Azerbaijan, which is not that very easy. It's going to cost you a lot of money. So, and if you do it in Azerbaijan, you have to translate into Russian and get it done there and spend money there. So
The professor is working there.
Huh?
Professor is working on that
Yeah,
plant.
yeah, you can do it, provided it has not been disclosed earlier in publications.
Yeah, I do.
Activity. Okay.
Thank you very, thanks, sir. Thank you.
I think there is no question. Let us have a big hand to the professor again for the
Thank you
nice
very much.
presentation.
Thank you to the audience as well. Thank you.
So I will call upon our last speaker of this session, Dr. Ronju Ahmed. He is assistant professor in the Department of Chemistry, Bangladesh University of Health Sciences. His main research interests include natural molecules and medicinal chemistry, emphasizing anti-diabetic and hepatoprotective medicinal plants, herbal products, and their relevance to public health through pharmacological efficacy and safety evaluation. So I'll call Dr. Mohammad Ronju Ahmed to start his deliberation. You have 25 minutes for talk.
Bismillahirrahmanirrahim. Respected chair of this session, learned audience, Assalamu alaikum and greetings. Today I will talk about the anti-diabetic potential and isolation of bioactive compounds from the 4 traditional medicinal plants. Before starting my session, I want to say something about these 2 people. Emeritus Professor Moshiuz Zaman, actually, who is the founding chairman of ANDAP, and he was the Emeritus Professor of Chemistry Department, University of Dhaka, also the chairman of BCSIR. Actually, he is my supervisor, mentor, and lifetime coach, because today is Dr. Ronju, actually, without his help, without his suggestion, it was totally impossible for me. So, hats of him and respect to him. Due to his physical condition, he was unable to come here. Another dynamic lady, he is the chair of this session. She is the mentor of my research work, and she is also the deans of our university. So I will talk about that first on the diabetes. Whether people will know all about the diabetes mellitus, that is characterized by a deficiency in insulin production or its action, or maybe the both. In 2021, approximately 537 million adults, and their age was 20 to 79 years, are living with diabetes. And in 2024, it was 589 million adults. And we expected to reach, it will maybe 643 million by 2030 and 783 million by 2045. So actually, diabetes mellitus is a heterogeneous metabolic disorder characterized by the alternation in the metabolism of carbohydrate, lipid, and protein. Synthetic anti-diabetic agents can produce the serious side effects. Therefore, it is crucial to develop new medicine or strategies to counter the huge increase in cases expected in the future. For the treatment of diabetes, commonly the strategy focused on the regulating and decreasing the blood sugar to fall within the normal level, mainly through the 3 oil. Number 1, stimulating the pancreatic beta cell to release the insulin. Number 2, inhibiting other hormones that elevate blood sugar. And number 3, that one is increasing the sensitivity of insulin receptor. By using the synthetic oral hypoglycemic together with the insulin, however, they are often limited in efficacy, carry the risks of adverse side effects often to cost. This constitutes the major force for finding the alternative mainly from the plant material.
diabetes and the plant material. There is a close relation between this. From the very beginning, the ancient people, before establishing the synthetic drug, the people used the plant medicine for all remedy of all kind of disease. So the plant material is very much important for the remedy of different kinds of disease. Plant kingdoms has always been the major mind for discovering the promising lead compounds for the drug development, because the main plants contain the substance that can be used for therapeutic purpose, of which are precursor for the synthetic substance. Before introduction of insulin in 1922, the treatment of diabetes mellitus relied mainly on the diabetic methods, which included to the use of traditional plant therapies. Many traditional plants for the treatment of diabetes exist, but few have received the scientific or medicinal evidence to be useful in diabetes. Ethnobotanical information suggests that about 800 plant species may possess the anti-diabetic potential. Several of them have been used for prevention of management of diabetes in Native Americans, South Americans, Asian, as well as the Africans. Biological action of the plant are related to the chemical composition that such as maybe the phenolics, alkaloids, flavonoids, flavonoids, coumarins, and glycosides. On the other hand, many conventional drugs for the diabetes, such as metformin, has first the plant origin. So, the searching for the new anti-diabetic drug from these huge plant resources is still attractive because they contain the substances which demonstrate the alternative and safe effects on diabetes mellitus. Our respected team members, our respected supervisor mentors, they have screened more than 95 plants from Bangladesh and other countries like Nepal, India, Pakistan, Cameroon, and Malaysia. In collaboration with the Department of Chemistry, University of Dhaka, DCSIR, now it is established in Bangladesh University of Health Sciences. From the source of plant materials to the experimental laboratory, systematic procedures are followed, includes the plant selection, collection, extraction, isolation, and evaluation of its efficacy. For the continuation of the study, I have selected 4 medicinal plants for the analysis. Number 1 is Glynas oppositifolius. Number 2 is Phlogacanthus thyrsiphloras. 3 is Moringa oleifera. And the finally 4 number is Gynura procamina. These all traditional medicinal plants have long been used in our region for managing the diabetes and related disorders. These plants are rich in bioactive compounds, natural molecules with the potential anti-hyperglycemic and antioxidant properties. While the traditional use offers clues, scientific validation through the experimental studies is essential to confirm their safety, efficacy, and underlying mechanism. So, our primary objective were to evaluate the anti-diabetic efficacy of 4 selected medicinal plants. Another objective was to assess their lipid-lowering effects and influence the hepatic glycogen content, and also isolate and identifying the bioactive compounds which are responsible for these pharmacological activities. For this study, we have collected these 4 plants from different regions of Bangladesh, except the Phlogacanthus thyrsiphloras, because these plants were collected from Assam, India. One of our fellow of ANRAP, Raisha Rautri, collected this plant flowers from Assam. And for the identification against these 4 plants, we have collected the species deposited to the Bangladesh National Herbarium, and specimen number were taken from BNH, that means Bangladesh National Herbarium. For the extraction, we have collected the materials
and wire air dried. Sometimes we have used the oven for drying and followed by ground into the powder form to obtain the extract of dry plant material. This dried sample was initially extracted with aqueous 80% methanol, or sometimes I used the aqueous 80% ethanol to obtain the crude extract. And this crude extract were used for the pharmacological study, that is biological experiment. And for the chemical study, I have then again successively partitioned into the solvent, varying polarity to obtain the NH part, then the dichloromethane part, then ethyl acetate, then N-butanol and aqueous extract respectively. For the chemical analysis, the active extract function by the fractionate by the column chromatography, that is glass column. I also use the PTLC. And finally, for the isolation of compound, I have used the HPLC using the silica gel C18 column and Sepadex LH20. Purified fraction are tested again for the further fraction for isolation pure compounds, and we are trying to evaluate its pharmacological activity after collection the large amount. For the biological studies, we have used the long Evans rat. Generally, their weight was 250 to 300 grams in our study. The animals were bred at our university. That name is Bangladesh University of Health Sciences Animal House, Dhaka, Bangladesh, and all the conditions are maintained at the standard procedure. The experiment was conducted according to the ethical guidelines approved by the Bangladesh University of Health Sciences Ethical Review Committee. The anti-diabetic properties of the 4 selected plants are evaluated in type 2 diabetic model rats. How will prepare this type 2?
Keep this.
And we all know that the streptozotocin were induced in the 48 hours old pup, and following the 3 months later, after the OGTT test, the rats are selected for the biological study. And blood samples are collected, kept under the fasting condition 12 hours by imposition of the tail tip, halogen anesthesia on the 0 day, and at the 28th day, animals were decapitated and blood was collected from the heart of the rat. Glucose measured, the God-Pep test, total cholesterol, that is lipid profile, and glycogen estimation are measured by sulfuric acid method. Now I will talk about a little bit about the genus Oppositefolius. Actually, this plant grows in the northern part of Bangladesh. I have collected these plants from the Nilphamari district, and it is called in the locally Dhimatita. So these plants are extracted with 80% methanol, and total 24 rats were used for this experimental group. The first group was normal water control group. Second group was diabetic mole rat as a control group without any medicine. Third group was the glycoside control group, and finally the fourth group was the 80% methanolic extract group, and which was treated 1.25 milligram gram per kg body weight. After treated the genus Oppositefolius methanolic extract, we can see here the subsequent treatment with the genus Oppositefolius, the serum glucose level decreased significantly, where the p-value was less than 0.003 at the end of the experimental compared to the 0-day value. And the glycoside treated group also decrease the blood glucose, serum glucose level significantly end of the 28 days experimental period compared to the baseline. For the lipid profile, we can see the table. There was significant reduction of triglyceride and total cholesterol level of Glinias oppositifolia, 80% methionine extract, and treated group compared to the baseline of the value. Moreover, high density lipoprotein, that is HDL level, also significantly increased in Glinias oppositifolia's treated group when at the end of the experiment. But there was no significant change or observed in the LDL cholesterol level. Effect of the hepatic glycogen content, we can see here the glycoside treated group showed the significant increase in the hepatic glycogen level compared to the diabetes water control group. And the Glinias oppositifolia treated group also increased the glycogen content significantly, where the p-value is less than 0.001 when compared to the diabetic water control group. Now, I would like to talk about a little bit about the isolation and characterization of 5 bioactive compounds from the Glinias oppositifolias. Total 5 compounds are isolated from the DCM extract because when we have extracted the partition, DCM part were performed the glass column, and lots number of more than 100 numbers of fractions were collected first time. Then I have fractionated according to the TLC spot, and finally the uses of using the HPLC, I have separated 5 compounds, and the first one was alpha spinesterol, leopiol, octacosane, beta citosterol, and the number 5 was the mixture of alpha amyrin and the beta amyrin. These 5 compounds actually characterized through the extensive analysis of FTIR, proton, carbon NMR spectrum, and followed by a comparison with the existing literature data, because these compounds already isolated by someone and the literature is available in the Google. This was actually 5 compounds which was collected, isolated from the Glinias oppositifolias. Then I want to talk about the information of Chlorantha fusciflora. This plant flower actually collected from the Assam, and it has also a significant result regarding the insulin level. Highly significant, it showed more than 5-fold increase the serum insulin level, and ethanol ester showed glycoside. Actually, glibenclamide was used for this study, and ethanol ester showed only 23% increase in the serum insulin level at the end of the study period compared to baseline level. Then I have also isolated another 5 compounds from this flower, and the same procedure I used for the isolation of this compound. But here, the first 4 compounds, that is beta citosterol, stigmasterol, 8-17-13 labradine, 15-16 olide, 19 oic acid, and 19-hydroxy, 8-17-13 labradine, 15-6 olide were isolated from the DCM extract of this flower. And the luteolin, number 5 compound, were isolated from the N-butanol part of methanol extract of this flower. And I want to give you this message. This is the first report of isolation of compound of 5 compounds from the flower of this plant by our research team. This is the structure of 5 compounds which are isolated from the Phloganthus thyrsiplorus. Now, I want to talk about the Moringa oleifera. Actually, in our country, this local name is Shuzna, and the leaves were used for the study. And if we describe the result, we can see that the treatment of aqueous 80% ethanol extract showed the significant reduction in fasting serum glucose level on 28th day. Glycoside treatment group also the significant reduction the blood glucose level on the 28th day compared to the 0-day value. Moringa oleifera decreased the cholesterol and triglyceride level significantly, and the liver glycogen content was increased by 39% after 28th day by the treatment of with Moringa oleifera. Then I want to talk about the Gynura procumbens. Gynura procumbens actually are collected from the our professor Hasina Banu madam, who have bought it from Australia and gave it to our national professor against other cancer. And in Mirpur, Bangladesh University of Health Sciences premises, we have cultivated these plants, and we did the study by this plant. Here, the ethanol extract we have used for the lipid profile test because actually there was no significant change were seen by our experiment regarding the glucose level lowering. We have did 2 times. Number 1 was aqueous ethanol extract, but no significant result were taken. And for the also we have used the water extract. In the same, we did not get any significant change regarding the serum glucose level. But the Gynura procumbens decreased the cholesterol and LDL level. And 80% ethanol extract gives Gynura procumbens also increased the HDL level compared with the 0-day versus 28 days. So I want to conclude the findings of this study demonstrate that the traditional medicinal plants of Bangladesh and Assam, India possess the promising anti-diabetic and lipid-lowering properties. Among the 4 plants investigated, Glynas oppositefolius and Moringa oleifera showed the significant reduction in fasting serum glucose, triglyceride, and total cholesterol, along with enhanced the hepatic glycogen storage. Phloganthus thyrsiplorus notably improved insulin secretion, while the Gynura procumbens exhibited moderate hypolipidemic activity. The isolation and structural elucidation of several bioactive phytochemicals include the sterol, terpenoids, flavonoids, provide the valuable insight into the chemical constituents responsible for this effect. I want to say and give some message. Based on the findings of the present study, it is recommended that a further detailed investigation be carried out to explore the molecular mechanism underlying the anti-diabetic and lipid lowering. Comprehensive toxicological evaluation should be performed. Development of standardized herbal formulation using the most potent extract. Finally, sustainable cultivation and conservation of these medicinal plants should be promoted to support future pharmacological research and application. I must get the opportunity to grateful our national professor Azad Khan sir, actually who is our umbrella, who is our banyan tree for the research for an academic purpose in Bangladesh. Without his help and continuous support, it was totally impossible to continue the research work. We all know that for the research work, we must need the money. Without money, research is impossible. And Professor Azad Khan sir always help us to get this money from different organizations from home and abroad. Another professor already I have said about Moshiud Downs and Rokia Madam. I also grateful to Professor Nirbhar Nahar, Iqbal Rao, Mamun, Shainullah Khan, Professor Mohammad Shoaib sir, and my co-worker Ashrafuzzaman, Mehdi Hasan Tushar, and Faruqi. I must say about my MS student, Amiyo Kumar, who have completed the MS degree from the Dhaka University, and now he is working in the RUET as a lecturer. Arjina, Maimuna, and Asamadat MS student. I must acknowledge Bangladesh Minister of Science and Technology for funding, ISP, ANDRAB, EPICS, and the BADAS and University of Dhaka. Another organization who is our team was tried a lot and give a lot of their intellectual input to establish the International Center for Natural Product Research. We still are optimistic, and inshallah we are trying to establish this center in Bangladesh. So thank you all for patient hearing. Assalamu alaikum.
The floor is now open for a couple of questions to the speaker. If you have.
Did you try to make any formulation out of these products?
Sorry.
Any product or formulation medically?
No, this is the single medicinal plant.
Yeah.
No product, no formulation. Only plant.
No combination. Did you combine? No.
No, no, single.
Any other question? Yeah, please go ahead.
Assalamu alaikum. These are the known plants.
Yeah.
Yeah. So these are different compounds you have isolated from the plant.
Plant.
So what kind of technique you use to identify and isolate the actual compound from the extract of the plant?
Next one.
Techniques you use.
Okay. The first I have used the 80% aqueous 80% ethanol extract. Then I did the solvent extraction by the separating funnel for the fraction. At first I washed the NX with the NXN. The non-polar compounds will be isolated by this compound, this solvent. Then I have used the DCM, then ethyl acetate, then N-butanol, finally the water extract. And from the DCM and ethyl acetate extract, I have performed the column chromatography, glass column. Then collected lots of more than 100 fractions. Then I did the TLC. And by seeing the TLC spot, I have mixed the same TLC spotted fractions in it. Then again, I performed the glass column with this fraction.
That's my question. After doing the TLC, you get a single spot on TLC, right? Then you confirm that there is only single compound in TLC. After the performing the TLC, how you can identify this is the actual compound you mentioned in your...
Not a single compound.
Yeah.
A group of compounds,
It's a
two or more, or three compounds.
You're
Then
talking about the class of alkaloids, terpenoids. Is this, if I'm not wrong, you're talking about the class of drugs.
Class of drugs?
It's not a single compound, it's a class of compound, alkaloid or terpenes or flavonoids.
Yeah.
If I'm not wrong.
Yeah.
I think he thought that there were multiple spots from there he picked.
Exactly.
Further, okay? I think he has slip of tongue that he said they're single spot.
So did you publish the article of your research work?
Yeah, already I published with the Flogata Floras compound. Already I published. And
in which paper you have to mention?
Don't
Remember? Okay. Thank you very much. Let us have a big hand to the speaker. And I would like to say that all the speakers delivered very nicely and the lectures were up to the mark. And let us have a big hand for all the speakers. I think this is the end of this session, and the organizers will announce what they need to do afterwards. Thank you very much.
So we have tea outside the auditorium, so you all can join us. Thank you.